the 32nd Bihar PEDICON 2023. So let's now begin, let's now commence the event. And to inaugurate the session, we already had Dr. Ashok Kumar, sir. So thank you so much, sir, for coming and for guiding us. And with his due permission, we are going to start the event now. And firstly, I would like to invite our honorable chairpersons to please come on the stage and to chair the first session, which is going to be on sepsis, what is new. So to chair this session, I'd like to invite the chairpersons, Dr. Somendu Mukherjee, Dr. Mani Shankar, and Dr. Om Prakash. So all the respected doctors, all the renowned guests are requested to please sit, and then we are going to begin the first topic, challenges and management in late preterm. And to speak on this session, I'd like to invite Dr. Lalan Bharti. Okay, so we are going to start the topic, challenges and management in late preterm. This is the first topic, and to chair this topic, we already have all the doctors on the board, Dr. Somendu Mukherjee, Dr. Mani Shankar, and Dr. Om Prakash. I'd like to request all the doctors to please settle down.
Whether this is connected or not.
मैं चाहूँगी कि साउंड ऑपरेटर की तरफ से एंड एलईडी वॉल की तरफ से जो भी हैं, प्लीज़ कम ऑन द स्टेज एंड प्लीज़ कनेक्ट द एलईडी विद द लैपटॉप जल्दी. So this event is organized and hosted by Darbhanga Academic of Pediatrics, IAP Darbhanga branch, and this is the scientific program.
Hello.
So now I request everybody's attention on the LED wall right behind me, as we are going to start the first topic, which is challenges and management in late preterm.
So warm welcome to Dr. Lalan Bharti. He is MD, FNNF, FIAP Fellow, Afro Advanced South Africa, HOD Pediatrics, JPG Hospital, Government of the NCT Delhi. He has many credits in CAP. He is EVCIP member 2022-23, President IAP East Delhi, Zonal Coordinator of IAP NNF NRP project, National Joint Coordinator of IAP under 5 mortality, President NNF Delhi 2022, Vice President NNF India 2021, Secretary General NNF India 2029-20, Joint Secretary cum Treasurer 2017-18, Delhi State Academic Coordinator IP NNF NRP FGM 2016-20. He major achievements are he is the executive editor of the Journal of Meteorology 2019-20. More than 37 publications in national and international journals, contributed to the NRP book India, also written and reviewed the multiple chapters in the various books. He is the national faculty and master trainer of home-based care, NRP India, NRP FGM, FBNC, KMC, pre-term care package, NSK, NTEP, NC, ECD, points, etc. He is from this Mithila, and she has a special affection for this place, and he contributed too much of the development of Bihar, IAP, and this Darbhanga. He visited this place many times as instructor, and previous day he was the lead instructor in the advanced NRP. So I request Dr. Lalan Bharti to start his talk.
So thank you, sir. Thank you very much for the kind introduction and blessing. I am overwhelmed attending this conference. At the outset, I would like to thank the organizer, teacher, friends from this dharti for having me here. And I would also like to compliment and congratulate each and every member of the organizing committee for holding this conference in a very big way. कल हम लोग देख रहे थे कि all halls, all the 5 workshops were full. And सबसे अच्छा जो था कि that was the NRP because of you only. आज से 2 साल पहले IAP सेंट्रल ऑफिस everybody was saying कि बिहार में NRP नहीं हो रहा है. And after that, Somsekhar Nimbalkar is sitting here, and I think 2 years में lots of NRP has been done. And yesterday also, I was surprised to see, and I was very happy to see that more than 25% of the participants were from the OBG, Obs and Gynae. And that is really the need of the hours to decrease the neonatal mortality rate in the single digit of this region. ये शुरू लग गया क्या? हाँ, thank you. So now coming to the topic, I have been assigned to discuss on the challenges and care of the late preterm. So we all know globally around 15 million newborns are born every year preterm. And India contributes around 23% of that. That is a very large number. As per the definition, prematurity is birth before 37 complete week of gestation, and gestational age between 34 to 36 complete week is called late preterm, and this late preterm accounts for around 75% of the preterm birth. These groups, faster growing subgroup, and due to their more mature appearance, there has been a lapse in early recognition and management of late preterm. As you can see, the major cause of mortality is prematurity and low birth weight, constituting around 50% of the total mortality. And to bring down the neonatal mortality to single digits, we need to focus on the preterm infants, especially the late preterm, which constitutes around 75% of the preterm group. So I shall be discussing case scenario, some terminology, incidence, what are the risk factors for late preterm, role of antenatal corticosteroid in late preterm, mortality, morbidity, long-term outcome, and discharge criteria. And all these will be discussed with respect to evidence, practice, and guidelines. So coming to the case scenario, I'm going to start with the case scenario. This is a 40-year-old primee, 12 years of infertility, treatment, has multiple failed IVF, and now it's 35 plus 5 days. This lady is on regular ANC visit. All scans normal, and fetal weight is 2.7 kg. This is not on the steroid. This mother didn't receive any antenatal corticosteroid, and present in the casualty with leaking for 2 hours with mild labor pain. Ultrasonography of amniotic fluid index is normal. That is value is 2 to 25 centimeter. And the parents are very anxious. So now the question is, where to go? Should we continue this pregnancy or should we terminate the pregnancy? So there has been a shift in the distribution of birth away from the term and post-term towards the earlier gestation because of the use of antenatal corticosteroids, ART, elderly mothers. So how prematurity are defined and various components. So extremely preterm are less than 28 weeks, very preterm 28 to 31 week, moderately is 32 to 33 plus 6 weeks, late preterm that is 34 to 37 week, and early term that is 37 to 38 plus 6 week, and this chunk has higher mortality and morbidity than the infant born at 39 week of gestation. So mortality in late preterm rises with each week lost in gestation below 39 weeks. Late preterms has higher morbidity and mortality rate than the term infants because of the relative physiological and metabolic immaturity, often the same size of the weight and as the term baby. And they have issues beyond neonatal period also. 2 to 3 times increased risk of hospitalization in this baby, and long-term neurodevelopmental morbidities are there in late preterm baby. So 34 to 41 post-gestational age is most crucial period, as 1/3 of the brain growth during this period. The various CNS and the non-CNS complications are mentioned here, like ADDSD, behavioral problem, cerebral palsy, vision, hearing loss, emotional disturbance, and the non-CNS problems include recurrent LRTI, asthma, diabetes, and malabsorption syndrome. So different studies have shown that the late preterm shows poor scholastic performance, behavioral disability, language difficulty, attention deficit, and higher need of special schools during the early school days, that is during the KG. And the same study have also shown that the late preterm have poor scholastic performance in later school days also. So factors significantly contributing for increased incidence of late preterms are increased demand for assisted reproductive technology, increased incidence of cesarean section, birth delay, cesarean section, and delayed childbearing age group. And another very important factor that could be contributing in late preterm is decreasing trends of vaginal delivery after previous LSCS. Other factors that includes are maternal systemic illness like maternal obesity, diabetes, preeclampsia, and intraamniotic fluid infections. Now coming to the causes of late preterm births, the causes could be medically indicated like preterm labor, prolonged rupture of membranes, or medical intervention like cesarean sections or planned induction of the labor for preeclampsia, fetal growth restriction, gestational diabetes, and so on. And physician practice pattern and risk benefit determination also contribute to the late preterm, like concern for risk of adverse effect if we continue the pregnancy, and the convenience of the parents, doctors, and family member to undergo cesarean section. The iatrogenic causes cesarean or planned induction of the labor without any indication include the induction of the labor or cesarean section on maternal request, fear of the neonatal risk with vaginal delivery, HIE, brachial plexus injury, and other birth trauma, for the risk of genital tract or perinatal injury, and the perception that the cesarean delivery is easier and less stressful than the vaginal delivery. Now coming to the antenatal corticosteroid in late preterm. So antenatal corticosteroid has shown decrease the need for the non-invasive ventilation in first 72 hours, decrease severe respiratory morbidity, decrease use of surfactant, need for resuscitation at birth, decrease incidence of bronchopulmonary dysplasia, and decrease incidence of TTNB. However, there is increased incidence of hypoglycemia and increased incidence of presumed neonatal sepsis if we use antenatal steroid during late preterm delivery. There is a definite risk of hypoglycemia due to antenatal corticosteroid in late preterm, adverse effect of which on the neurodevelopmental outcome is not known, and there is doubtful role of ACTH on RDS, apnea, or need of mechanical ventilation, and duration of hospital stay, incidence of chorioamnionitis or endometritis. So ALPS trial, which was published in NGM, showed that the administration of betamethasone to women at risk for late preterm delivers significantly reduced rate of neonatal respiratory complications. However, in the same study, also shown that there was a high rate of neonatal hypoglycemia, increased risk of sepsis, and not associated with longer hospitalization or adverse event. There was no difference in chorioamnionitis and endometritis. So these are the recommendations for use of antenatal corticosteroid during late preterm delivery. Different professional bodies have their own opinion, but there is no consensus, and WHO recommend that there is no need of using antenatal corticosteroid during late preterm. So the guideline says now that the antenatal corticosteroid therapy is not recommended for women undergoing planned cesarean section at 34 week to 36 plus 6 days. So now coming to the same case scenario, this is the 4 hour after admission. Leaking continue.
2 minutes left.
Leaking continue, contraction is less. Now high grade of maternal pyrexia, antibiotic has started, and mother underwent LSCS and baby delivered. Now baby has respiratory distress, grunt, subcostal retraction, heart rate is 158, SpO2 80%. So this is the common situation. If the mother deliver late preterm, soon after birth, the baby present like this scenario. Now the question is how we ensure normal transition of this late preterm. What are the criteria for NICU admission? What are the respiratory morbidity? Does the management strategy differ from the term baby? So let us see. So for normal transition, we must ensure that there should be the trained person in the labor room. If possible, this baby mother should be transferred to the higher center where there are the facility for CPAP and other respiratory modality. And we must ensure delayed cord clamping, skin-to-skin contact, and we must ensure the observation of this baby for 48 hours and monitor this baby. The NICU admission criteria, again, here it is written less than 2,000 gram, but it varies from the institute to institute. In government setting, it is 1.8 gram, but in the corporate and private setting, it is less than 200 grams. Other indications are already mentioned here, like tachypnea, hypoglycemia, hypothermia, dehydration. So coming to the other morbidity, the late preterm neonates have higher risk of respiratory morbidity, hypoglycemia, temperature instability, hyperbilirubinemia, feeding difficulty when compared with their term counterpart. So morbidity, the late preterm have increased risk of morbidity as compared to the term neonate during different periods, like perinatal mortality is 8-fold higher as compared to the term baby. Neonatal mortality around 6-fold higher, and infant mortality 3.5-fold higher. And this baby has also increased risk of sudden infant death. So these are the discharge criteria. Baby can be discharged home when vitals are stable, baby is euthermic, euglycemic, and these infants should be discharged only after 48 hours of birth. And also make sure that vaccination has been given, newborn screening has been done, and post-discharge medical care and follow-up visit scheduled for 24 to 48 hours of the discharge. If discharged within 7 days, after 7 days, then the follow-up should be done within 7 days of the discharge. And family should be counseled properly for the care of this baby. Danger sign has to be explained when to bring this baby back. Now coming to what are the post-discharge issue of this baby. So this baby require 2 times more readmission because of jaundice, feeding problem, and suspected infection, respiratory problem, vomiting, crying, or bronchiolitis. So long-term neurodevelopment outcome of this late preterms are, so we all know that at birth, the brain mass of the late preterm is 70% that of the term baby, and myelination is not completed yet. So there is increased risk of cerebral palsy and mental retardation compared with the term baby. So a strategy to reduce the late preterm births are, there should be a balance, the risk benefit for continuing pregnancy and expectant management versus early delivery. We should follow the evidence-based medicine when deciding on delivering for maternal or fetal indication like hypertension, GDM, and so on, and elective LSCS to be planned only after 39 weeks of gestation unless there is medically indicated. So finally, to summarize, the late preterm infant born between 34 to 36 weeks and represent about 2/3 of all the premature neonates. Often, these babies are overlooked because of their large size. When compared with the very premature infants, these are vulnerable to high morbidity involving nearly every organ system because of the physiological and structural immaturity. Neonatal mortality is around 5 times, and infant mortality is around 3 times higher than the term infants. Neurodevelopmental impairment has especially been concerned for these infants. We need to follow evidence-based medicine when deciding on to delivering this baby or continue this pregnancy. Antenatal corticosteroid in late preterm is not recommended, and for that further studies are needed to establish stroll, elective cesarean section to be planned only after 39 week of gestation, prevention of preventable preterm birth should be high priority and should be urgently addressed by all the stakeholders to bring down the neonatal mortality to single digit.
Thank
So
you,
thank
Dr. Lalan Bharti sir, for this very relevant and relevant in our day-to-day to practice. And most of our NICU beds are consumed by these patients. So we thank for bringing this
Thank you, sir.
issue to you.
Thanks, Dr. Lalan sir. I would like to invite any question to our learned audience if there is any queries. I think Dr. Lalan sir has touched all the topics. If you have any queries, kindly raise your hand.
For memento, please
Okay,
collect
thank you, thank
in the
you.
rear side of this hall, and we shall have a good moment for delivering you the mementos. All of the speakers and chairpersons are requested to collect at the rear side of this hall. Thank you very much.
Thank you, sir.
Thank you so much, everyone, for your kind and patient listening. And
Thank you, sir.
thank you so much, everyone, for your kind and patient listening. And now we are going to discuss our next topic, which is sepsis, what is new. So to chair this session, I'd like to invite Dr. Vijay Kumar Chaudhary, the Assistant Professor of DMCH Darbhanga, Dr. Rupesh Kumar, who is the Senior Consultant Neonatology, Yashvi Children Hospital, and also Dr. Amulya Ratan, Pediatric Consultant at Shiv Sharda Memorial Hospital and Research Center, Donar, Darbhanga. So all of the chairpersons are requested to kindly take their respected seats over there. Dr. Vijay Kumar Chaudhary, Dr. Rupesh Kumar, and Dr. Amulya Ratan. And our next topic is going to be sepsis, what is new. And our keynote speaker is going to be Dr. Ashutosh Sinha. So can we have Dr. Ashutosh Sinha on board?
Can we get the slides here? Welcome, Dr. Ashutosh Sinha, sir. As we all know that he is a learned pediatrician and academician, and it is very nice to have him. He has done MBBS, DCS, MD, and MRCP from UK, fellowships PICU from UK, PG and diploma in allergies, asthma from UK, and MSc Health Management, LSE London. He has very vast work experience. He has worked in Fortis Hospital Noida and ZIP Hospital Noida and Imperial College of Healthcare and NHS Trust London, UK. So kindly proceed, sir.
Hi, thanks a lot for the introduction. I'm Dr. Ashutosh. So, backing of intensive care, so I'm an intensivist, core intensivist. So, the topic which I've chosen is close to all the intensivists actually, whoever practices intensive care. This is something which is, which we deal with day in, day out, and very challenging. Why challenging? Because sepsis is, I call it like a heart failure or maybe something like a myocardial infarction. So you have got a very limited time frame where you have to act and act fast to change the outcome. The outcome purely depends upon your identification of the problem and management. So that's why the guidelines have come up, recommendations are there so that there's an uniformity of management of a septic child. Now, sepsis has been a very leading cause of morbidity and mortality globally. I mean, all over the world, if there is a delay in identification and management, the mortality can increase from somewhere from 4% to 40 to 50%. So if we want to decrease the mortality, we need to act fast and we need to act accordingly. Accordingly means according to the guidelines that is suggested. Right. Page down. I think it's not working.
PPT is not moving. Slide.
This one is not working. It's not connected to Bluetooth. Maybe I will ask you to change the slide, whoever is controlling it.
चेंज कीजिए
Next, मैं next बोलूँगा तो आप change कर लेना. Right. So in this talk, what I'm going to cover is first is definition. So to identify any problem, you need to have a definition. Then only you can identify that yes, this is septic and what stage of sepsis it is. So definition and what's new in definition, that's we are going to discuss. We'll talk about the surviving sepsis campaign guidelines. And accordingly, we will see how we are going to manage sepsis and septic shock patients with antimicrobials, fluid therapy, hemodynamic monitoring, vasoactive medications, ventilation, and the role of corticosteroids and immunoglobulin. Now, each of these topics are actually a talk in itself. I mean, but I've tried to concise it so that it does not become too much for you guys. So next slide, please. Yeah. So this came up in Times of India in 2012. It's quite an old news where it says 1 in 4 ICU patients get sepsis and 1 in 2 patient dies. So this is a very significant number. Now over the years, this has decreased. Definitely the number of admissions in ICUs and number of patients dying has also significantly decreased. But globally, 4 to 8% of patients admitted in ICUs are septic or septic shock patients, and the mortality ranges from somewhere between 8 to 40% depending upon where the child is, what kind of intensive care the child is, and which area of the world the child is in. Next slide, please. Now, it's really unfortunate actually that the Surviving Sepsis campaign releases the first children's sepsis guidelines in 2020. So all these years we have been following the adult guidelines. So the Surviving Sepsis guidelines has been mainly focused on adult patients, and we have been extrapolating data and guidelines and information from those papers. So, now, the Surviving Sepsis campaign was formed by the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. Why was it made? So that we have a uniform guidelines and treatment protocols so that we can decrease the mortality and morbidity in patients. If we can identify the patients early and treat it very fast, and then these mortality and morbidity decreases significantly. Next slide, please. Now, my talk is based mainly on this paper. So this paper was published in Critical Care Pediatric Journal, as well as intensive care journals, and it's Surviving Sepsis Campaign International Guidelines for the Management of Septic Shock and Sepsis-Associated Organ Dysfunction in Children. So it's basically purely meant for children, starting from 37 weeks onwards. This one? Yeah. So Surviving Sepsis Campaign international guidelines for the management of septic shock and sepsis-associated organ dysfunction in children. Now, I've been fortunate enough to be working with some of the authors here, like Mark Peters, David Inward, Simon Edel, and these have been my mentors, and some of my colleagues, like Akash Dev, had been my colleagues there in UK. And it's very proud to see an Indian named Dr. Suchitra Ranjit. She is an intensivist in Chennai in this. So we would be discussing about this paper and the guidelines from there. Now, when we talk about definition, so definition of sepsis is very important because from there only we can diagnose what kind of stage this patient is on, whether the patient is in septic shock or sepsis with organ dysfunction. So we'll go shortly about these. The first definition came up in 1992, and it says sepsis is defined as a systemic immune response syndrome, SIRS. We used to read about these when we were doing MDs. In addition to sepsis, severe sepsis is defined as sepsis-associated organ dysfunction with hypoperfusion. And septic shock may be hypotension, but only when it is not responsive to fluid therapies and the child is needing vasoactive agent. So this was the first definition, 1992. Over the years, Surviving Sepsis Campaign came in 2001, and some definitions have been revised every 4 years. But the most recent came with this in 2016, where they call it as Sepsis 3, where they made some important changes. The first important change was they removed the term SIRS, Systemic Inflammatory Response Syndrome, and severe sepsis. What they have said is sepsis is now defined as life-threatening organ failure caused by host inappropriate response to infection. And organ failure is now considered if there is a change in sequential sepsis-related organ failure. So they came up with a SOFA scoring. SOFA scoring, where 2 points or more are associated with hospital mortality of more than 10%. So if the child is having those, if you do an assessment and SOFA scoring is more than 2, then the mortality risk increases significantly. And septic shock is defined as subtype of sepsis and manifested by circulatory, cellular, and metabolic instability associated with high risk of death than sepsis itself. Then pediatric sepsis. Those recommendations were mainly from the adult patients. Then came pediatric sepsis. Now, if you look at the pediatric sepsis guidelines, the first guideline came from International Pediatric Sepsis Conference, which was published in 2005, and the definition has been extrapolated from there. And they have defined sepsis in 3 forms: sepsis, severe sepsis, and septic shock. But septic shock in children as acute infection leading to cardiovascular dysfunction. I mean, there's slight changes in definitions and the meaning of it. What they're trying to say is there are only 2 types of sepsis now, which is severe sepsis and sepsis-associated organ dysfunction. So severe organ dysfunction, septic shock and severe sepsis-associated organ. These are the 2 forms. So in sepsis-associated organ dysfunction, the child has severe infection leading to cardiovascular and or non-cardiovascular organ dysfunction. So this was an important difference. Now, we have identified sepsis. We have identified the child has come and the child has got a septic shock or sepsis-associated organ dysfunction. Now, what to do? How we are going to manage these kind of children? So when we come to management, now it comes as a bundle of care. Bundle of care means you need to do certain things in certain period of time so that the risk of mortality decreases and the child stabilizes. The first thing first important thing that has come up is antimicrobial therapy. Now, the timing of antimicrobial therapy is very important. If you identify a child to be in severe sepsis or sepsis-associated organ dysfunction, then you need to give the antibiotic within 1 hour. And if the child does not have any organ dysfunction, then you have some leeway. You can give the antibiotics within 3 hours, because there are so many RCTs which suggest that if the antibiotics are given within 1 hour, the risk of mortality decreases significantly. Then comes the choice of antibiotics. What kind of antibiotics you're going to give. So that also depends upon where you're practicing, what kind of antimicrobial resistance pattern you are seeing, and what kind of community-acquired infections you are seeing, and antibiogram as well. But in my practice and in most of the intensivist practice, if there is a community-acquired infection that a child has come up with without any proper focus, I mean, Cept reaction, single agent can be given as a first-line therapy. Otherwise, if you want to have a broad coverage and the child is very sick and you're not sure about the organism, you can start with meropenem and vancomycin, and then also depends upon what the background history of the child is. The child has been in hospital for some time or was discharged from hospital recently, then you need to give a broader coverage to cover MRSA as well and hospital-acquired infections. If the child has a central line, then your antibiotic choice has to be either coverage of staph and strep, and if the child has any abdominal issues, then also accordingly. So depending upon what the child has, you need to decide on type of antibiotics. And consideration for the age and site of infection we discussed. Now once a child comes, the first thing that should be given should be considered when you send for investigation is blood culture. Blood culture is one of the most important investigations that should be done in any child who presents in emergency department with high fever, altered mental status, very poor peripheral perfusion, or hypotension. And because that helps in deciding on targeted therapy. Suppose after 3 days you get a blood culture positive, then you can decide on what kind of antibiotics you are going to give. Now, there are a lot of RCTs that you don't have to treat with 3 antibiotics if there is a sensitivity. You can treat with 1 or maximum 2 antibiotics there. And then rationalize the treatment, consider de-escalating the treatment every 48 hours, 20 to 48 hours, considering what antibiotics. Now, what antibiotics to continue and what we can discontinue. Now, when to stop the antibiotics and how we are going to decide on changing the antibiotics, upgrading or downgrading, that can be done through a biomarker. Procalcitonin we all know, but procalcitonin has been used and there's a lot of evidence as well that it's helpful in neonates and adults. But in pediatric practice, the evidence is low, and it's costly as well. So what I do and what most of the intensivists do is CRP. So you can track the course of your disease through CRP. If the CRP normalizes, you can actually stop the antibiotics early. You don't have to give it for 10 to 14 days always. Now, fluid therapy. This is a chapter in itself. And there are a lot of debates around fluid therapy, what fluid therapy, when to give, how much to give. There has been so many papers, RCTs, and debates on this. So now what the recommendation has been in this recent guidelines is, it depends upon whether you have got an intensive care or not. So if your healthcare setup don't have an intensive care, then IV bolus fluid should be avoided. You should not be giving lots of fluid boluses, maybe 1 fluid bolus of 20 ml per kg, and keep the child on maintenance therapy and start inotropes early. You can start the inotropes through peripheral line as well. These are the recommendations which are there. Now, if you have an intensive care, then the fluid bolus can be aggressive. You can give 20 to 40 to 60 ml per kg of fluids in 1 hour. But you should always be reassessing the child again and again to look for fluid overload, because if fluid overload is there, then the risk of mortality increases again. So positive balance in itself is a risk factor for mortality. So the panel, what they have suggested is using, now, once you have given the fluid therapy, you have decided on giving the fluid therapy, what kind of fluid you are going to give. Kind of fluid means, is it crystalloid, is it crystalloid? So the panel suggests using crystalloids rather than albumin for the initial resuscitation of children. So this is very clear, we need to use crystalloids. Now what are the, now this fluid therapy, this is a very landmark paper which came up in New England Journal of England, and this is the only randomized clinical trial to date to have evaluated the effect of fluid therapy in pediatric sepsis. After this paper, which was published in 2011, the recommendation have changed drastically. What this paper says that if you are going to give fluid boluses in critically ill children with impaired perfusion, then your mortality significantly increases, which is 48-hour mortality. But there are a lot of limitations on this study, and we have to interpret this study carefully. Because this study was done in Africa, where there was a lot of malnourished children, a lot of malaria cases. But what we find, and they excluded the gastroenteritis cases, there are so many other cases were excluded. So after this paper, the recommendation has changed, which I discussed in the previous one, that whether you have an intensive care or whether you don't have an intensive care. So if you have an intensive care, then give fluid therapies, monitor it, and I'll talk about monitoring as well, hemodynamic monitoring, and decide about how much to give and when to start inotropes. Now, when we talk about crystalloids, there are various forms of crystalloids, the choice of crystalloids. People have used human plasma, Frespro, FFP, we call it as, and Hartmann's and other solutions. But recently, what they're saying is whatever fluid you have available in your emergency department, like normal saline is most commonly available, so you give normal saline. You don't have to wait for albumin or Hartmann's. But the preferable fluid should be ringer lactate, or something which has come up newly is plasma-lite. I don't know how many people have used plasma-lite, but it's available in our hospitals, and Western countries routinely we used plasma-lite. But if you have a Ringer's lactate, you should use Ringer lactate as initial fluid resuscitation fluid. Why? Because the chloride load in this fluid, if you look at, is only 112, whether in normal saline it is 154. So the chloride in itself can cause hyperchloremic metabolic acidosis, which can worsen the hemodynamic situation of the child. So and you have to see what cost effectiveness. You can give albumin, but it's very costly, and that's why it's not recommended as an initial fluid, resuscitation fluid. So in summary, I mean, as I said, the fluid therapy in itself is a chapter. So, but we'll summarize the fluid therapy as, according to surviving sepsis guideline, the bolus indication pediatric sepsis are limited to hypotension. So if you have an hypotension, then only you give fluid boluses, regardless of health system, whether you have an intensive care or not. If you don't have an hypotension in any child, you should not be giving fluid therapy, fluid boluses. You can keep the child on maintenance therapy. Once the decision of volume expansion is taken, then the choice of fluid, what are the kind of fluid you are using, is going to determine the outcome of this. So this is also important. If you start giving colloids, then it might actually be detrimental to the child. Now, how much time we have? Okay. So hemodynamic monitoring. So this is what has been recommended, that if you have an intensive care, then you should be focusing on hemodynamic monitoring in any child who is having severe sepsis. Now, the target mean blood pressure, what they've recommended is 5th to 50th centile. So that's the target you should be keeping according to the age of the patient. And all these recommendations about mean arterial blood pressure, central venous pressure, these have all gone. Now, warm shock, cold shock, these have all they've gone out of window. These are not actually helpful in management. And what they are suggesting is you should start doing advanced hemodynamic monitoring with intra-arterial blood pressure, cardiac index monitoring, cardiac output and index monitoring, systemic vascular resistance, on those kind of monitoring. So this is kind of a normal range that you should be targeting about this. Now, these parameters can be measured through a machine we are available, ASCOM, there's a name of that machine, where you can put the probe above the suprasternal notch and you get all these findings. Now, the other thing which is very important in management of septic shock and sepsis-associated organ dysfunction is role of lactate in resuscitation. Now, these lactate actually can help you guide whether the child is properly resuscitated or not. If the child has a huge lactate more than 2, obviously he is not properly resuscitated. You need to target and try to bring the lactate to a normal level over the course of period of time. Now, elevated lactate is linked to poor outcome in children, although it is not a direct measure of tissue perfusion. So you can't say that tissue perfusion is impaired according to the different studies that we have. Now, choice of vasoactive medications. Earlier we used to say, okay, start dopamine if it is a cold shock, then start adrenaline if it is warm shock, then NORAD, those things are out of window. You can start any inotrope which is available at your emergency, maybe dopamine as well. But dopamine should be avoided, and adrenaline or noradrenaline, whichever you are comfortable with, you can start it. And also start after giving fluid bolus 40-60 ml per kg, and then assess and then start. And vasopressin can also be added according to need. Milrinone, yes, no, depending upon how comfortable you are with. I have used Milrinone with good effects. Ventilation. Now, ventilation, earlier they used to say, oh, intubate early, very early. Now the recommendation is, there is no recommendation of intubation. Whenever you feel comfortable, you should start the ventilation, but you can give a trial of non-invasive ventilation as well. I'll just skip this this slide, because inhaled nitric will not allow me to speak, it seems. Okay, just one more minute. Corticosteroids and IVIG. Now, corticosteroids are actually not recommended for use in catecholamine responsive shock. But here again, there is a hitch that if there is catecholamine non-responsive, you can try corticosteroid as a life-saving therapy, but not in usual cases. And IVIG, again, only in very specific cases like toxic shock syndrome. And where you are using IVIG, try to use polyclonic IVIG where they have IgM as well. And next is plasma exchange, renal replacement, and extracorporeal. What is new? Well, plasma exchange is not recommended. CRRT is recommended to take out your excess fluid. Yes, ECMO has come in a big way, where if you send the child to a high volume ECMO centers, the chances of survival increases. But how many centers have ECMO? There's hardly any. Thank you very much for your patience. Any questions?
Thank you, sir. Thank you for your giving the elaborated. Actually, shock is very vast topic. It's very difficult to cover in given frame of the time. That need, because each and every that needs detailed discussion. But in given frame of time, sir touched all the topic. Thank you, sir. We all got the benefit of all these things. So thank you, sir.
The speakers and chairpersons are requested to come in the rear side of this hall to collect their mementos. Thank you very much.
Thank you, sir.
Thank you so much, sir. Thank you so much to all the chairpersons. Thank you to the speaker. And now moving to the next keynote, which is evaluation of allergy, roadmap to effective diagnosis and health strategies. And to chair this topic, I'd love to invite on the stage, firstly, Dr. Suraj Nayak, a legendary pediatrician, served as professor, principal, and superintendent and dean of LNMU in a span of 40 years, and also Dr. Sanjay Kumar. Dr. Sanjay Kumar, who is the director and chief consultant of Shama Children Hospital. And I'd like to request Dr. Balmukund Jha, the consultant of Sarojini Health and Research Center. So I'd like to be requesting all of the three speakers, all of the three chairpersons to please come over to chair this session. And again, I'd like to draw attention of everyone for the topic, evaluation of allergy, roadmap to effective diagnosis and health strategies, and then the speaker, Dr. Arif Ahmed. Thank you so much.
Now I would like to call Dr. Arif Ahmed sir on the stage to come on mic. He give his great talk on evaluation of allergy, roadmap of effective diagnosis and health strategy. Dr. Arif Ahmed sir is a pediatrician allergist at national and international level. He studied graduation and post-graduation from the Seth GS Medical College. He worked as a senior resident in teaching hospital in Mumbai and also held same post in UK and USA. Now he is professor HOD Pediatrics Department of Sadan Medical College. He is director and allergist at Alarmi Center for Allergy and Chest Disease. he has done lot of research, publication on allergy, immunology at national and international level, and has written many books, papers, lectures, and participate many conference and workshops all over India and many presentation in UAE, USA, Europe. He got poster award at EAACI Hamburg 2003. Sir, please come on the stage.
Good morning. I welcome all of you in this scientific session. Now, Dr. Arif Ahmad from Hyderabad will continue his speech. Yes, start.
It's 14 minutes actually. On this one, it is 25 minutes. Okay. सबसे पहले मैं बिहार पेडिकॉन और ख़ासतौर हमारे दोस्त डॉक्टर ओम प्रकाश का मैं बहुत आभारी हूँ, कि है ना आप लोग ने मुझे यहाँ पर बुलाया है। एंड मैं दूसरी बार आ रहा हूँ, ये पहली बार नहीं है, इसके पहले हमने आके यहाँ पर BLS कोर्स किया है। तो ये जो हमारा जो टॉपिक है एवोल्यूशन ऑफ एलर्जी रोड मैप टू इफेक्टिव डायग्नोसिस एंड हेल्थ स्ट्रैटेजीज है। तो ओके, व्हाट इज अ हेल्दी लाइफस्टाइल? Okay, this is a healthy person, but definitely not a healthy lifestyle, okay? Why? This is across India, you will see such people in the rural areas who are slim, who are very active, and free of all allergic diseases, free of all lifestyle disorders such as hypertension and diabetes and all. Why? Because they are taking a food which is free of preservatives, additives, and colorants, and it is absolutely fresh without any of these colorants. Unfortunately, we are being subjected to a lifestyle which is totally devoid of it. So, if music is the food of love, play on, wrote William Shakespeare. So humankind over the years have abused food in various ways. And how they have done it, we'll see. Okay. So now this is the most important slide of my lecture. This is the evolution of mankind. We started off with the Stone Age, then we have the agricultural age, then we have the industrial age, and last is the information technology age. Now, why is this very important? Now, the last one which you're seeing, the information technology age, it does not correspond to the time lag on this slide, because that is just 50 years. It could be just a dot, hardly a dot on this. So when we started off with the Stone Age. And during the Stone Age, we were hunter-gatherers, foraging for food, and we used to eat for most of the time it was uncooked food because fire was not discovered. And the food which was taken was taken very fast, and at any time whenever we would get the food, because we had to protect ourselves. So our entire gastrointestinal system, our GI system, our body system evolved during this Stone Age, okay? And it has kept itself intact since then. But then what happened, the agricultural age came, which lasted around, so the Stone Age lasted millions of years, then the agricultural age which lasted for just 10,000 to 20,000 years. And that is when we started growing crops. And the first crop we grew was wheat. And it is not surprising that most of our disorders that we have of food is related to wheat. Then we had the industrial age, which lasted 200 years, and it was during this time when we started eating food at fixed times, morning, afternoon, night, or maybe late in the night, when we started preserving food, but still our lifestyle was not sedentary. Our lifestyle was very active, okay? And it was, so the diseases were just started evolving, which we are seeing now. But ultimately, in the last 50 years, we have this informational technology age, where food has become abundant. Food has become rampant, food has become cheap and very varied. You can be sitting over here and get anything from anywhere in the world at the switch of a button. So that's how life has become. It all comes at a cost. With food, with all these preservatives, additives, and colorants coming in and causing your health problem. So what are these? And the most important problem, the lifestyle problem, which you have, allergy. So what is allergy? It refers to a hypersensitivity that occurs upon re-exposure to a sensitizing allergen causing release of inflammatory mediators. Now the word allergen is very important.
What is an allergen? Allergen is always a protein molecule, a living molecule, because you cannot be allergic to smoke, perfume, deodorants. These are all irritants. Unfortunately, this is the concept in the community that you can be allergic to smoke, perfumes, and deodorants. You are only allergic to protein molecules such as dust mite, cat, dog, cockroach, dander, fungi, or food substances. Next. What the hygiene hypothesis is, this gives a plausible explanation for the incidence of allergies throughout the world. So earlier we used to live among nature with this gobar around here. What is the importance of gobar? It contains endotoxins which would protect us from allergies. We used to live among farm animals which would protect us from allergies. Then we had many children in the families. Because of many children in the families, what happened is there were repeated viral and bacterial infections, and these repeated viral and bacterial infections would protect the children and develop the innate immunity which would prevent allergies. And this has been proved in the West, where children have gone to a day care center at a particular age, had lesser allergies as those who did not go to the daycare center. So it is suggested that atopic disease is the price paid by those in the West for the relative freedom from virus, bacteria, and helminth infections. And now in India, we have the Government of India program where we deworm the child every year. So with the worm infestation coming down, the incidence of allergies will also go up. Next, this is the changing pattern in the developed regions. Now what you see out here is that in the 60s, there was an increase in the respiratory allergies. Then around in the 80s, they plateaued out, okay, because of the increased use of inhalation therapy. And from the beginning of the century, we have the increased incidence of food allergy and eczema. This is of the West. This is what is going to happen in India with increased westernization of our lifestyle, with increased testing. And why this is very important is that already we are seeing a lot of food allergies and eczema in NRI kids, children who are born and brought up in the West, because of their change in lifestyle. So this shows the prevalence of food allergies, which is quite rampant. So what are the adverse reactions to food? It could be divided as immune-mediated or non-immune mediated, or it could be toxic. Immune-mediated, it is food allergy. Non-immune mediated would be known as food intolerance. And food allergy could mainly is IgE mediated, which can lead, most dangerous thing is anaphylaxis. Non-IgE mediated will lead to a chronic disorder such as food protein-induced colitis or your enteropathies. And you could have a mixed IgE and non-IgE. So, food allergy is the term which we describe for anything. I mean, if I don't like you, I say I'm allergic to you. So it's a very misnomer which is being used. Food allergy has a very strict terminology, and it's the one which can cause deaths. However, not all symptoms after ingestion of a specific food are due to an allergic or immunological mechanism. So basically, you have to know what is food allergy and food intolerance. Food intolerance can be because of any food. Food allergy is more commonly because of certain, especially fish, shellfish, milk, and eggs. And this can lead to death, while food intolerance will not lead you to death. Right? So, now, how do you investigate? There is nothing more deceptive than the obvious fact. A patient comes to me, they always say I'm allergic to something because I'm an allergist, okay? Remember, the person who is found at the site of the crime is not necessarily the person who has committed the crime. And even if you are found at the site of the crime, at least 2 to 3, 4 times is not confirmed that you are the person unless and until you are caught. So you have to prove it, that that particular item is causing it. Unless and until you prove it, you cannot be considered. So what you see and hear need not be true food allergy. Okay, so this is a prick-to-prick test where you prick the fruit or you prick the vegetable and you prick the skin, wait for 20 minutes and see a reaction. And this is very important because, I remember my father, he had this concept that he was suffering from tomato allergy, and all his life, he did not eat tomatoes. Sometimes my mother would slip in a tomato and nothing would happen to him. But later when he would be told that there was a tomato in the curry, he would immediately start retching or start scratching and all that. So this is known as psychological food intolerance. So if I would have the prick-to-prick test at that time, I would have just pricked the tomato, pricked his skin, and seen the reaction. So it's a very simple test which you all can practice in your clinic. So we'll come to the first case. 10-month NRI girl with atopic dermatitis, bottle-fed first month, breastfeeding, weaned at 6 months, strict vegetarians, okay? But was of both mother and baby were off milk totally since they reacted adversely to milk in the form of a severe reaction. So we did the testing and these were the results, okay? We have the just a little bit volume, skin prick test and we have the specific IgE. Why I'm showing you these results is that everything which is race is not necessarily you are allergic to it. Take this child milk was only 51, but this child reacted very adversely. Well, the almond was 89.40 and the child was taking almond freely. So the message out here is clinical reactivity is more important than what you see out over here. Irrespective, maybe more than 100, yes, you can stop the particular food item. But if anything, you have to see clinically. Don't go by the figures strictly, in the strict sense. Next is we have an 18-year-old male who developed articular rashes and swelling of lips immediately within 30 minutes of eating seafood such as prawns and shrimps, okay? There was no rashes on consuming fish or any other foods. The rash would subside in 24 hours with or without treatment. No history of any respiratory complaints or GI complaints. Patient not on any medication, but he never developed anaphylaxis. Sometimes he would eat prawns, he would get a rash. Sometimes he would not eat prawns, and sometimes you would get a rash, sometimes you would not get a rash. Now the important thing out here, if you are allergic to a particular food item, you will always get a rash with that particular food. Then why was this person not getting a rash with prawns sometimes? Well, let's look at it. So the skin prick test for prawns was negative. The total, all aeroallergens, including seafood, was negative. Only mealworm component 10M was positive with a value of 0.34. So this is a new test which we have where it looks at the components. Now I'll give the end result was why this prawn was, why this patient was getting reaction with prawn sometimes and sometimes not getting a reaction. The reason was when he was given wild prawns, that is sea prawns, there was no reaction. But when he was given farm prawns, he was getting a reaction. He was actually allergic to that mealworm, which was being fed to the prawns in the fish, in the prawn farms. Okay, in the prawn farms, the prawns are fed mealworms, okay, to make them grow big and all. So this is very important. You really have to sometimes go into the details to find out what they actually cause it, because there could be something or the other, and that's why this new test known as component resolved diagnosis is very helpful. So that's the CRD-based interpretation where sensitization to edible insects, mealworm, was detected. Right. Now case 3, very interesting. 5-year-old male child, we strictly breastfed, came at the age of 5 years. History of repeated episodes of vomiting, especially following milk ingestion and constant nasal congestion. In infancy, rash on milk ingestion stopped, restarted 1 year back, but no rash had developed. No family history of allergies. Family strict vegetarians, including egg. But the last line is the most important thing out here. Cat in neighbor's house and cattle bred in another immediate neighbor's house. On examination, except inferior turbinate hypertrophy, no significant finding. So this is a child who comes with repeated vomiting and strict vegetarians. And ultimately what we find is we do the test and all the allergens which we test for, everything the report is negative. So what comes positive is a component known as BOS D6. It's a heat labile allergen from cow's milk and beef. Cross-reactivity in BOS D6 and other members of the serum albumin allergen is usually high. So what this was basically, he had beef allergy. How a vegetarian is getting beef allergy? That's the interesting part. Beef allergy can be caused via sensitization to serum albumin or via sensitization to alpha-gal, a heat-resistant sugar in non-primate mammals. Clinical reaction to alpha-gal often have a delay of 3 to 6 hours. Tick bites are the main sensitization route. So environment of the child was conducive to the outcome. Highly unhygienic cattle were infested with ticks, which probably led to the positivity in spite of never consuming meat in the family. So there is a new thing which is known as alpha-gal. You can develop beef allergy, even if you are strict vegetarians, if you have cattle bred in and around your house in a very unhygienic condition. So that's this new test will pick it up. Now, what is the treatment? We have a very famous saying in our country, na rahega baans, na bajegi bansuri. The simple meaning is that if the flute is not there, there'll be no tune. So the best way to avoid food allergy or any allergy is to avoid the allergen if it is possible. Okay, so the definite treatment is immunotherapy, which is of two forms, sublingual immunotherapy and subcutaneous immunotherapy. This is more for only for aeroallergens. For food, we have only for peanut. Otherwise, for generally, we do not have for food allergies. So which one is the best? It is equipoise, considering taking everything into consideration. So what is the prevention? The way you think, the way you behave, the way you eat can influence your life by 30 to 50 years. I think everybody agrees with this point out here. So the prevention starts, there's this famous Barker's hypothesis that whatever your diseases you're going to develop later, whether it's diabetes, hypertension, it all starts from the antenatal period. So for the prevention of it, it has to start right from antenatal period. So then your breastfeeding, weaning, healthy diets, junks, colorants, NIN guidelines are the last, okay? So what is the antenatal? The role of the environment. Indian children born and brought up in the West have the same incidence as the white children. This is because the gene is there. Now they are being exposed to the Western environment, that's why they are developing allergies. While we in India we are being protected because of our lifestyle. And that's what the lifestyle is. I'll come to it later. Okay, so breastfeeding, everybody agrees it should be strictly followed and which has a role in prevention of allergies. Now, this is a Leaf study, and this is a very famous study, and why it's very important for us. Now, what they had is 600 children aged 4 to 11 who had a high risk for peanut allergy. Half was made to avoid peanut, the other half was made to consume peanut. The one which avoided peanut, 17% developed peanut allergy. While in the one who consumed peanut, only 3% developed peanut allergy. But for us in India, we have this traditional weaning diets known as Anna Prashasan, where from the age of 6 months, we start weaning of the child and giving them natural home-cooked food. And this is what is protecting our children from developing food allergies. So it is very essential that we should continue this practice of home-based, home-prepared foods to prevent allergies in a future generation. And that is why in my book, I have come up with these master chef recipes or healthy diets for families, for mothers who are working and who do not know what home-based diets should be made and all. And that's what we need to disseminate amongst the parents and all, what healthy diets they should be using for the children between 6 months to 2 years of age. Right. So definition and identification of undesirable food. So we have the fast food. 1 minute. Okay. Right. Okay. So we have the fast food, we have the junk foods, and ultra-processed food. All fast food is not bad because your cut vegetables and your salads and cut fruits is also fast food. Ultra-processed foods are not healthy, but they have all the micronutrients, and one of them is your powdered milk, which you give. It is non-deficient in micronutrients and minerals because of the addition and all, but basically it has preservatives and other substances which can be detrimental to your child. So junks is the junk foods, ultra-processed foods, nutritionally inappropriate foods, caffeinated colors, carbonated foods, beverages, and sugar-sweetened beverages. This is the terminology which has been brought up by the Indian Academy of Pediatrics to deal with the unhealthy foods, which we have to strictly debar our children from consuming. Because it interferes with the nutritional quality, it causes overweight and obesity, it leads to cardiometabolic risk, it leads to high blood pressure and behavioral symptoms. Nowadays, there's an epidemic of behavioral problems in our children, and that is why it is very, very important that you should emphasize, because most of these behavioral disturbances in our children could be because of this processed food which they are consuming, which is very high in salt and sugar. Fruit juices is a very interesting thing. Is very commonly among pediatricians, there is a tendency to encourage fruit juices and all, but fruit juices should be discouraged in the first 2 years because what they should encourage is whole fruit supply, because the whole fruit supplies fibers and phytochemicals to the diet, and child skills like peeling, chewing, and differentiating between colors, textures, and shapes. While giving fruit juices can lead to picky feeding can lead to constipation, flatulence, and diarrhea and other problems. So you should avoid fruit juices. Okay, so encourage intake of regional and seasonal whole fruits over fruit juices. Fruit juices should not be offered to infants and young children below the age of 2 years. This is the important point which you have to keep in mind. Now we come to the last case. A 14-year-old boy with a history of wheeze in childhood developed articular rash and swelling of lips in ordering Hyderabadi biryani from a takeaway. He responded to emergency treatment in the ER. History of similar but mild episodes in past on takeaway biryani. No such episodes on home-cooked biryani. A SPT test on the contents of the home-cooked biryani were negative. So this, this is a very common scene which you see. That the particular food cooked at home, nothing happens. When it is ordered from outside, there is a reaction. Because now to make food more attractive and more to make it sell, because for various reasons, food is being colored, and that is why all these colorants can cause problems in children. So, the food additives that comes to make the food attractive, because over centuries color was added to make it naturally attractive, like natural colors stored, and food was stored for longer periods of time, but we used to use natural preservatives. Now it's all artificial preservatives which are being used to improve the sales and profits and make it more palatable and desirable by adding more salt and sugar. So these are the entire list of classification of the food additives. So and each one comes with a number on the food package. The preservatives, antioxidants, sequestrants, humectants, bleaching and maturing agents, emulsifiers, and all these have a role in all the food which is being packaged in the supermarkets. And therefore, these are all the ones, if they are consumed in excess quantity, in a limited quantity, it's okay. But if they are consumed in excess quantity, they can lead to hypertension, diabetes, and allergic disorders. So lastly, the route out is NIN guidelines. So NIN guidelines is what everybody is out practicing out here, but on 2 points I would like to emphasize is promote exclusive breastfeeding for 6 months and encourage breastfeeding till 2 years if possible. Feed home-based semi-solid foods to the infant after 6 months. The question, and the most controversial point which NIN guideline, and a very important point which NIN guidelines have brought about is that what happens is the mother cannot breastfeed the child. Most of the other guidelines, including IAP, they talked about formula feeding. But NIN guideline says give animal milk. And for the first 1 month, you can dilute the animal milk, but after 1 month, it should be given undiluted. That is a very important point, because they have taken into consideration that India is a vast country of different strata, where many of the people, the population, cannot afford formula feeding. And that is why they have talked about animal milk if the breastfeeding cannot be done for some reason or the other. Others are just all natural things which you should know. I mean, eat plenty of vegetables and fruits, ensure moderate use of edible oils, avoid overeating, exercise regularly, restrict salt intake to a minimum, ensure the use of safe and clean methods, adopt the right pre-cooking process and appropriate cooking methods. And one of the simple thing is, do not wash cut vegetables or cut fruit, because that removes the nutrients and all, as simple as that. So one should go through these NIN guidelines and all, which they have given with the points to ponder, which I have mentioned in my book, and you should all go through it. Okay, so with these words, I would like that this is my book, Winning Over Allergies, Myths and Facts, which was released by the governor of Telangana. And my latest book is Overcoming Food Allergies, Your Roadmap to Effective Diagnosis and Health Strategies, and which most of the things I have summarized through my lecture, and you will find it very useful. With these words, I thank you one and thank you all. I finish in time.
Hello. Thank you, Dr. Arif Ahmad sir. You have given a very good presentation. Marvelous. Now, the session is open for any question and answer. Yeah.
Yes.
You can ask.
पूछ लीजिए, सुनना देगा.
My question relates to peanut allergy, and question is based on my personal observation. First, let me tell my observation. we have been seeing here in India कि हम लोग चिनिया बादाम फोड़ के खाते हैं. चिनिया बादाम बोले तो मूंगफली, बोले तो सिंगदाना. So हजारों आदमी, करोड़ों आदमी यहाँ चिनिया बादाम फोड़ के खाते हैं. आज तक इतने साल में, more than 75 years एज है मेरा, आज तक किसी को एलर्जी नहीं देखा. लेकिन यूएसए में मैंने एक 10 साल की लड़की को मूंगफली दिखाया और उसकी सांसें फूलने लगी.
Very good
So
point.
does it have any relation to ethnicity and nationality?
No, you have made a very good point, and this has been studied. This has been studied because the way the peanut is prepared, there the peanut is roasted to very high temperatures, which makes it allergenic. Well, in India, we do mild roasting, or most of the time it is boiled. That's why in the Orient, entire Orient, there is no peanut, there's hardly any peanut allergy. But in the West, especially in America, because of the way they prepare the peanuts, roasting to high temperature, which makes it more allergenic, and why we have peanut allergy. That is the reason, because of the preparations.
Thank you. No.
Nothing to do with it.
Doctor.
Indian children born and brought up in the West have a high incidence of peanut allergy.
Last question, Dr. Arif. Very good preamble you have given. I would like to ask one question. What is the minimum age of testing of allergy? Minimum age.
Minimum age, a blood test you can start from birth itself, your specific IgE.
And skin.
But skin prick test, the earlier you do the skin prick test, the reactivity of the skin is very low.
Yeah.
So after 2 years, the reactivity of the skin is much better. So after 2 years, you can rely more on the skin prick test as compared to this one.
Okay, thank
Because
you.
of the reactivity.
Thank you.
Yeah, I think there's a question.
Maybe the last question. It was excellent talk actually, Dr. Arif. And being an allergist myself, I sometimes have this confusion about which you had after the LEAP study and NIN guidelines you said about, early introduction of the cow's milk protein.
No, only using animal milk if human milk is not available.
Yeah.
For those people, because what is happening across the country is many guidelines say no, you should use only formula feeding, not animal milk. They have been but the rural poor cannot afford. The urban poor cannot afford formula feeds.
Exactly. So, the LEAP study contradicts in itself. The LEAP study says introduce early to prevent allergies.
Proteins.
Proteins. Now, if you look at ARI guidelines and those guidelines, they will say to delay the cow's milk protein allergy and, so that it does not develop allergy. I mean, this is something which contradicts that one. That's the only particular for this one. And this another, the peanut one also, I think they are ARIA protein, that component, and then genetic susceptibility as well, which promotes that allergy.
Could be.
Further
So now you have an important point. Now coming to this cow's milk. Now we are in the state of Bihar, and in our tradition we have been fed cow's milk from generations and all. In infancy and nothing, we have never developed cow's milk allergy. So when it comes to cow's milk, I'm a little bit skeptical about it because whether the baby food industry had a hand behind this whole hype about cow's milk allergy, that is the point which I cannot, is two question mark on that.
So
Yes.
excellent talk, Dr. Arif, as usual. The only point that you were mentioning about the animal milk and formula milk. So
I knew you'd come up with it.
So no guideline is mentioning that formula milk should be given. The best milk is mother milk. If mother milk is not available, then lots of human milk bank is available. If that is also not available, then recommendation is the formula milk, and nowhere it is mentioned that the human milk should be given.
Nowhere should be given what?
Human milk to the newborn.
Animal milk.
Yeah, animal milk.
But the NIN guidelines, that is why I brought it up.
We
NIN
are objecting that guideline. We are not expecting that guideline.
But
and
you have
if-
to accept that NIN is a very thorough body which has done enough.
This message should not go to the general pediatrician that the human milk.
Sir, we have IMNCI guidelines, and sir, previous night examined all the counselors, and they found that IMNCI, Shankar Prasad ji has told us, and in that guideline it is written, if the mother milk is not given, it should be either cow's or buffalo milk.
So
and
you
it
see-
is in practice in our Darbhanga.
Yes, I'm glad you brought up Dr. But
Thank you. Now,
IMNCI guidelines में सारे यही हैं सर.
next
Now
question.
question session is over. Now I will request all the chairpersons and speakers to go to the rear side of the, for collecting their mementos.
Thank you so much, everyone, for your kind and patient listening. Now, we are going to cover another topic, which is medical practices in 2024. Yeah, this is the topic. And to chair this session up, I'd like to invite Dr. Rizwan Haider, who is the professor of pediatrics at Darbhanga Medical College, and also Dr. Chitranjan Datta, who is a tutor, assistant professor, associate professor, and HOD in Pathology Department of Darbhanga Medical College, and also Dr. Suman Mishra, who is senior consultant at Sparsh Childcare, Patna. So the next topic we are going to cover is medical practices in 2024. And to chair this session up, I would like to invite Dr. Rizwan Haider, Dr. Chitranjan Datta, and Dr. Suman Mishra. So all the chairpersons have already come up on the stage. So I'd like to invite the next keynote speaker, Dr. Amar Verma. And I'd like to request the chairpersons to please introduce all the audience to Dr. Amar Verma. Thank you so much.
Very good morning. Dr. Amar Verma need no introduction, but it's my pleasure to say something about Dr. Amar Verma, sir. He is MBBS Gold Medalist, MD, DCH, PhD, MICP, and WHO Fellow of Geneva. He is Professor HOD, Department of Pediatrics, Ranchi Medical College, Ranchi. Formerly, he was a State Immunization Officer of Government of Bihar, first coordinator of first pulse polio program in Bihar, Jharkhand, worked with the WHO, UNICEF and World Bank. He was past national president of IAP Genetics Chapter, president East Zone, past president East Zone, president Jharkhand State, president Ranchi IAP, published 34 research papers and written many books. And he has written 2 books, editor of 2 journals. He was awarded fellowship in nephrology from INSBHU, master trainer of hemophilia program from Istanbul, Turkey, and master trainer of ethics in medical research, Bangkok, Thailand. Fellow of International College of Pediatrician, MICP 94, Fellow of Indian Academy of Pediatrics 20, Fellow of Pediatrics Association of India 2021, and Shishu Visheshak Shiromani Award awardee 2020. Now you can start.
Thank you, sir, and thanks the audience. I'm really thankful to the organizing committee of PEDICON Bihar, and I'm equally indebted to the chairpersons who have given my introduction. I'm a very small and humble person, but basically these things I will start, that why I chose this topic, rather why this topic came into my mind. For last, say 20 years, I have been talking about my specialization, rather genetics, and other advances of the pediatrics. But this time I thought that basically in my 40 years of practice, what we have done, every time there is always a feeling that whenever the blame is, onus is always on the doctors. whether it is media, whether it is the academia, whether everything, the academia very docilely they take up, yes, we are wrong. Medias, the trials are there. So what will be the practice? The thing is this, that this particular topic evoked many, many emotions in me. But at the same time, since it was in Darbhanga, though I'm a bit confused what to talk, what not to talk, but since it was in Darbhanga, it created a situation where I feel very, very at ease. In fact, the whole world, I must say, it is like this, कि कोई हाथ भी न मिलाएगा जो गले मिलोगे तपाक से, कोई हाथ भी न मिलाएगा जो गले मिलोगे तपाक से, ये नए मिजाज का शहर है, जरा फासले से मिला करो. बट दरभंगा में जब मैं इंटर किया तो फासले खत्म हो गए. I met our seniors 40 years back, we were transported, we had nice discussion. So in these circumstances, I thought that I should discuss this, what is our future? The first thing is this, that government always says that health is your responsibility. अरे भाई क्या बात है, डॉक्टर हो गए तो सारा दुनिया का हेल्थ हमको देखना है क्या? उसके लिए हमको शर्मिंदा भी होना है? कारण किसी और का है. So first of all, we have to think about, is health a privilege, a right or a responsibility? इस तीनों शब्द पर आप लोग ध्यान दीजिएगा. Is health a privilege, a right, a responsibility? यूज ऑफ राइट आजकल बहुत ज़्यादा है. लाल पीला हरा कोई भी कलर देखिए, सब बात करेगा मेरा अधिकार, मेरा संवैधानिक अधिकार, मेरा ये है, मेरा वो है. अरे भाई डॉक्टर का क्या है? नो गवर्नमेंट इज परमिटेड टू टेक अवे योर फ्री स्पीच, रिलीजन, इक्वलिटी कोई सरकार नहीं ले सकती आपसे. लेकिन कहीं भी ये लिस्ट में आपने देखा है एनीवेयर दैट देयर इज एनीथिंग मस्ट बी गिवन टू यू बाय अदर्स? कोई अधिकार है कि ये आपको देना है? साहब मिस्टर ए का है, मिस्टर बी को ये चीज़ देना है, चाहे कैसे भी हो जाए. अब मिस्टर ए रो रहे हैं, भूखे हैं, कुछ है, कोई फर्क नहीं पड़ने वाला, मिस्टर बी तो लेके रहेंगे. Rights are limitation on government power, and these are the freedoms which are yours, not obligation, which you are due from somebody else. कोई आपका ऐसा अधिकार नहीं है जिसको आपको दूसरे से लेना है. What is implicit in a right is a protection. Please ध्यान दीजिए शब्दों पर. What is implicit in a right is a protection, but not a gift of goods and services created because of the work, sweat, time, capital, investment of others. आज हेल्थ के, ह्यूमन राइट्स के क्या क्या इतना चलता है. हिंदुस्तान के बाहर जाए, हिंदुस्तान में भी अब ये फैशन है जिसको आजकल हम लोग एक परजीवी या आंदोलन जीवी कहते हैं. सब चीज़ हमको चाहिए, आपका ये भी चाहिए, आपका ये भी चाहिए. आप क्या करेंगे साहब? हम कुछ नहीं करेंगे, हम तो हो गए यहाँ, हमको सब कुछ चाहिए. सो राइट आपका प्रोटेक्शन है, गिफ्ट नहीं है. और हम लोगों को खास करके डॉक्टर्स को शर्मिंदा इसलिए किया जाता है कि आपको सब कुछ करना है, आपको करने के लिए कोई सामान नहीं देंगे, ना पैसा, ना बजट, ना फंड, लेकिन करना सब आप ही को है. पेशेंट सीरियस आए तो आपको देखना है, पेशेंट मर जाए तो आपको उसका भोगना है. सो देयर इज द डिफरेंस ऑफ राइट्स एंड इंटाइटलमेंट. अब आपको एज ए डॉक्टर, हमारे मेरे ख्याल से 99% डॉक्टर्स को समझ नहीं है कि राइट क्या है और प्रिविलेज और इंटाइटलमेंट क्या है. जिस दिन हम लोग ये समझ जाएंगे उस दिन हम लोगों की जो आज फजीहत वो नहीं होगी. वी हैव टू अंडरस्टैंड दैट. सो राइट्स आर यूनिवर्सल इन नेचर एंड राइट्स आर इनफ्रीक्वेंटली मॉडिफाइड. राइट क्या है? संविधान में लिखा हुआ आपका अधिकार है. अधिकार चेंज भी होता है, कहीं किसी एसोसिएशन में आपका अधिकार है वो चेंज भी होता है. लेकिन इंटाइटलमेंट डिफर करता है प्लेस टू प्लेस, टाइम टू टाइम. क्यों? बिकॉज दे आर इन मोस्ट केसेस पेड फॉर बाय द इंडिविजुअल्स हु आर नॉट द बेनिफिशियरीज. आज हिंदुस्तान में हम लोग कितने लोग टैक्स देते हैं? एक रफ डाटा करीब तकरीबन 4% से 5% के बीच में. इस डाटा में मैंने थोड़ा और झांकने की कोशिश की तो प्रोफेशनल्स कितने हैं? लगभग मोर देन 50% उसमें टैक्स देने वाले प्रोफेशनल्स हैं. सब नौकरी वाले नहीं हैं. 50% टैक्स देने वाले प्रोफेशनल्स हैं जिन्होंने अपने माता पिता का पैसा, अपना कमाया हुआ पैसा, कर्ज लिया हुआ पैसा, सब कुछ लगा करके अपना एक कमाने का, अपना रोजगार का एक धंधा खड़ा किया। आपने मेहनत की, उस समय कोई पूछने नहीं आ रहा है आपको, लेकिन जब आप मेहनत में सफल हो रहे हैं तो आपका हिसाब लेने के लिए पूरा पूरा विभाग खड़ा है। कभी सोचा है आपने? डॉक्टर्स आर एक्सप्लॉयटेड लॉट. So where India has been going wrong, it is unable to decide if the health is a right or responsibility or a privilege. आज तक ये डिसीजन नहीं हुआ है। आप पैदा हो गए हिंदुस्तान में, हेल्थ आपका राइट है। अरे साहब, आप दिन भर दारू पी रहे हैं, रोज आप इधर उधर का खा रहे हैं, क्या कर रहे हैं क्या नहीं कर रहे हैं, सब कुछ है, लेकिन हेल्थ आपको चाहिए। और अगर किसी जगह आपकी हेल्थ खराब होती है तो प्रिंसिपल साहब हमारे बैठे हैं सामने, मिश्रा जी जिम्मेवार है, फांसी चढ़ा दो। सुपरिटेंडेंट जिम्मेवार हैं, फांसी चढ़ा दो। हेड ऑफ डिपार्टमेंट जिम्मेवार है। अरे साहब, सारा दिन आप खुद किए हैं। आप किसी नर्सिंग होम में जाते हैं तो वो तो दुकान है उनकी, पैसा नहीं देंगे, क्यों? बहुत डॉक्टर लूट रहा है। सो इट हैज टू बी राइट। अगर लोग राइट मान के चलते हैं तो इट मस्ट बी इंटायरली स्टेट कंट्रोल। आपका एक नया पैसा नहीं लगना चाहिए, चाहे प्राइवेट में जाते हैं चाहे कहीं भी जाते हैं, सब कुछ सरकार को देना चाहिए, जिस सरकार का फंडिंग हम लोग टैक्स से देते हैं। नाउ हेल्थ केयर एंड इंटाइटलमेंट नॉट राइट, इस बात को डॉक्टर समझ लीजिए। आपको ये डिस्कशन में मदद भी मिलेगी। कभी भी आप अपना केस, हम लोग जब भी लड़ते हैं डॉक्टर्स के ऊपर, जब भी कंज्यूमर कोर्ट में केस आता है, डॉक्टर्स हमेशा दबे हुए रहते हैं। हमारे पास तो ये साधन नहीं था, ये दवाई उस दिन नहीं मिली, हमारा नर्सिंग होम में ये प्रॉब्लम था, हमारे डिपार्टमेंट में फंड नहीं आया है। अरे साहब, क्या है, आप राइट तो नहीं दे रहे, इंटाइटलमेंट दे रहे हैं उनको, जिसको देना आपका फर्ज है, जिसको एक हिपोक्रेटिक ओथ के नाम से हम लोगों पर उड़ा दिया गया है। तो सीधी सी बात है, अगर आप मर्सिडीज खरीदने का पैसा दे रहे हैं तो मर्सिडीज आप खरीदेंगे ना, आपके बदले मर्सिडीज खरीद के आपको कोई और दूसरा तो नहीं देगा। ऐसा होना चाहिए ना। कितना बड़ा फैलेसी हम लोग के पूरे कॉन्स्टिट्यूशंस के नाम पे चल रहा है, इस डेमोक्रेसी के नाम पर। When society purchases a good, it is an individual who gets the good, but those paying for the good are not necessarily the same individual as those receiving the good. अब बताइए क्या बात है, मजेदार है साहब। मेरे बगल में आप रहते हैं, आपने मेहनत किया, आपने एक बड़ी गाड़ी खरीदी, अब हम कहेंगे साहब हमको भी दे दो, क्योंकि हम बगल में रहते हैं आपके, कैसे आप चढ़ेंगे? हम अकेले हैं, हम भी तो चढ़ेंगे, चाबी दे दो, हम लेके आते हैं। सो अगेन व्हाट इज द प्रॉब्लम? ये दिक्कत कहाँ है? आप हंसते खेलते वोट देके चले आते हैं, सब खुश, बहुत बढ़िया, जिंदाबाद। साहब जिंदाबाद तो कर रहे हैं, मेहनत आप कर रहे हैं, तो आप क्या बन गए? कभी सोचिए इस पे। सो दिस थिंग हैज टू बी डिसाइडेड बाय द गवर्नमेंट, डॉक्टर्स बॉडीज। ये आवाज हम लोग को उठानी होगी कि डॉक्टर्स बॉडी में हम डॉक्टर हो गए, इट इज नॉट अ फ्रीक ऑफ एक्सीडेंट। 20 साल पढ़ के मेहनत किए करके इस पर आए हैं कि हम कुछ कर सकें और कुछ ले सकें, हम उसके लिए अपने मेहनत का चार्ज ले रहे हैं आपसे। नाउ गवर्नमेंट ऑफ इंडिया बहुत सारे काम कर रही है, सरकारी काम के ऊपर हम लोग क्यों नहीं आक्षेप कर सकते हैं, क्योंकि सरकार के पास बहुत बड़ा काम है, अच्छा काम भी कर रहे हैं, जिस काम पे एक छोटा सा पुर्जा हम लोग भी हैं। लेकिन इस सारे कार्यक्रम के बीच में डायलेमा यही है कि हु विल पे फॉर योर हेल्थ केयर, यू और अदर्स। ये डिसीजन हम लोगों को अपने पहले हेल्थ बॉडीज में करना है। अगर आपका हेल्थ केयर को राइट बना दिया गया तो सब कुछ सरकार को करना है। अमीर गरीब नहीं देखना है, धर्म जाति नहीं देखना है। हिंदुस्तान में पैदा हो गए हम लोग, जो भी हैं हमारा, ये आपको देखना है हमारा सब कुछ। लेकिन अगर प्राइवेट फोर्सेज उसको बैलेंस कर रहा है तो प्राइवेट फोर्स अपना घर में कहाँ से लाएंगे पैसा? कैसे क्लिनिक बनाएंगे, कैसे रोज नया इंस्ट्रूमेंट्स लाएंगे, कैसे ट्रेनिंग लेंगे? उसको भी सब्सिडाइज करना होगा। अगर आप नहीं करते हैं तो यू आर इन द रॉन्ग बॉक्स, और हम लोग नहीं मांग करते हैं, सो वी आर इन द रॉन्ग बॉक्स। सो अनदर एस्पेक्ट, एक दूसरा एस्पेक्ट और सोचिए। एक तो ये का एस्पेक्ट सोचने का है, दूसरा एस्पेक्ट सोचिए कि इफ एज ए ट्रीटिंग डॉक्टर यू डिसाइड द कोर्स ऑफ ट्रीटमेंट। गलत कर रहा हूं या सही? इफ एज ए ट्रीटिंग डॉक्टर यू डिसाइड द कोर्स ऑफ ट्रीटमेंट, गलत कर रहा हूं या सही? सही कह रहा हूं? यही पढ़ाया गया है हम लोगों को. Who is going to take decision for the welfare of the patient? Doctor, people or law? कृपया इस पे ध्यान से सोचिए. कौन डिसीजन है? जब भी आप ट्रीट करते हैं, इमरजेंसी सी सेक्शन आया, बैठ के ट्रीट कर रहे हैं, पीडियाट्रिशियन हाथ बांध के खड़ा है, भाई जल्दी से निकले, बच्चा को करें. और एकाएक डायरेक्शन आता है कि बच्चे को उत्तर दक्षिण नहीं, पूरब पश्चिम रखो. ये डिसीजन आपको नहीं लेना, वो आ गया ऊपर से. वो लेने वाले कोई फलना बाबू हैं जिन्होंने जिंदगी भर मेडिकल का एम नहीं पढ़ा, कहीं से लॉयर हो गए आके बैठ गए, उसके बाद आपको डिसाइड कर रहे हैं. उधर से एक एडमिनिस्ट्रेशन का ए आ गया, आपको डिसाइड कर रहा है, डॉक्टर साहब क्या कर रहे हैं आप, सोच लीजिए कुछ होने वाला है आपके ऊपर. भाई आप सी सेक्शन कर रहे हैं, बैठ के देख रहे हैं न्यू बॉर्न को, और दिमाग में पीछे पीछे भाई कहाँ फंसेंगे. मैं ये कहता हूं दावे के साथ कि 100% डॉक्टर्स के माइंड में ये काम चलता रहता है. Whenever they see a patient, 100%. अगर कोई कहता है कि नहीं चलता है तो झूठ कहता है. मेरे दिमाग में चलता है. 50% जो काम मैं पहले करता था आज नहीं करता हूं, और जो मैं कर सकता हूं वो नहीं करता. इस सिचुएशन पर भी आप सोचिए. ये दूसरा नंबर का पॉइंट है जिसको हर डॉक्टर को सोचना चाहिए. एक टेक्सास वुमेन का केस अभी हाल में 1 हफ्ता पहले का था. उसको इमरजेंसी ऑपरेशन की, एबॉर्शन की जरूरत थी. टेक्सास का लॉ बहुत खतरनाक लॉ है. अगर आप किसी वीमेन का एबॉर्शन के किसी भी एंगल पर पकड़े गए तो आपको कम से कम 10 साल, ऊपर से फाइनेंशियल, और शायद आपके ऊपर मर्डर का केस भी चलाया जाए. ये है. उनको जजेस ने कहा कि नहीं साहब एबॉर्शन नहीं करेंगे. ये एडवर्ड सिंड्रोम का केस था. एडवर्ड सिंड्रोम का केस में उनको मोर्टैलिटी होने वाली थी, कोई उपाय नहीं था उसके अलावा. शी हैज टू फ्ली. वो छोड़ कर दूसरे जगह चली गई. वहां जाके अबॉर्शन कराया. उस पर एक सज्जन ने केस किया है सुप्रीम कोर्ट पर कि कनाइवेंस था डॉक्टर्स को और दूसरे जगह के डॉक्टर्स के साथ मिलके इन्होंने ऐसा किया, जबकि उस स्टेट में ऐसा कोई बात नहीं है, उन्हें करा सकते हैं अबॉर्शन. ये आपके यहाँ भी होगा. ज्यादा दिन नहीं है. आजकल मीडिया बहुत नजदीक लिया है पूरी दुनिया को. आपके यहाँ भी ये होगा. तो आप क्या करेंगे? पहले से सोच के रखिए. जवाब आपके पास नहीं है, क्योंकि जब भी इस तरह का कोई बात होती है, पता नहीं कितने लोग आप लोग फेस किए हैं कोर्ट को, दबी दबी हंसी के साथ आपसे क्वेश्चन पूछा जाता है. पान खा के आराम से दांत दबा के आपसे क्वेश्चन, हाँ डॉक्टर साहब बोलिए. अब पीछे में बात होता है, बहुत कमाता था, हम गए थे तो हमको बैठा दिया था किनारे, इसलिए इसको हम देख लेंगे. बड़े मजे से बात होती है. तो अगर आपको इस सिचुएशन में नहीं पढ़ना है तो पहले से सोच के रखिए जवाब. स्टेटस डॉक्टर्स का 24 में क्या होने जा रहा है आप जान रहे हैं. अभी हमारे पास 742 मेडिकल कॉलेजेस है. मालूम है, ये 3 दिन पहले का ये डेटा है. 742 मेडिकल कॉलेज. जिस समय हम लोग ग्रेजुएशन कर रहे थे पूरे हिंदुस्तान में 95 मेडिकल कॉलेज थे. हमारे टीचर्स के समय 24 मेडिकल कॉलेज. आज 742 मेडिकल कॉलेज. तो आप सीधा जोड़ लीजिए कि एचओडी पीडियाट्रिक्स कितना होगा, उसको 2 से 3 से गुना कर लीजिए. इतने लोग एचओडी हैं जो सब के सब तोप और 30 मार खा हैं. कोई एचओडी किसी को से कम अपने को नहीं समझता है, और आपके खिलाफ भी एविडेंस देने से नहीं चुकेगा. मैं जानता हूं ऐसे कुछ लोग हैं, जस्ट बिकॉज कि एक मीडिया में फोटो निकल जाए, आपको फांसी चढ़ जाए, उससे उनको कोई मतलब नहीं है. इस सिचुएशन में आप फीस रेगुलेट नहीं कर सकते हैं, आप किसी को कुछ कर नहीं सकते हैं, तो आप क्या पढ़ाएंगे, कैसे पढ़ाएंगे? How many doctors needs and does the doctor per 1,000 statistics has it got a value? ये भी एक मजेदार बात है. क्या कहा जाता है कि अमेरिका में हर 20-25 मरीज पर एक डॉक्टर है, शायद 35 या समथिंग कुछ है. हिंदुस्तान में 1000 के ऊपर एक डॉक्टर है, 1000 से ज्यादा है, समथिंग लाइक दिस. आप ये बताइए कि डॉक्टर्स का स्टैटिस्टिक्स, और दूसरा आप कहिए कि आप हिंदुस्तान में एरोप्लेन खरीदने हैं तो पर हेड कितना एरोप्लेन चाहिए? अरे भाई इंफ्रास्ट्रक्चर है नहीं, ना एयरपोर्ट है, ना आपके पास पायलट्स है, ना कुछ है, और डिसीजन पर 1000 ले रहे हैं. डॉक्टर्स की बात है ना, मेडिकल कॉलेज है जो 742 हम बोल रहे हैं, इसमें से कम 20 मेडिकल कॉलेज इंस्पेक्शन करने का मौका मिला है. वहाँ जाने के बाद एक जगह तो मैं जान बचा के भागा, एक जगह मैंने उनको समझाया कि बंधु अब आप सेफ नहीं रहिएगा, आपको भी मैं देख लूँगा, मेरे यहाँ आइएगा तब, इसलिए चुपचाप से निकलने दीजिए, जो सही बात है मैं लिख के जाऊँगा. तो ना मेडिकल कॉलेज का इंफ्रास्ट्रक्चर है, ना डॉक्टर्स के पढ़ाई की जगह है, ना टीचर्स को अच्छा पे मिल रहा है। एक मेडिकल कॉलेज में एक फैकल्टी, सुबह में मैं पहुंचा, शाम को पता चला कि यहाँ के सारे फैकल्टी आ गए हैं, ज्वाइन कर लिया। आप देख लीजिए स्टैटिस्टिक्स पूरा है। जब अंदर से पूछा तो पता चला कि उनके 50% फैकल्टी एक दिन पहले रिलीव होकर दूसरे मेडिकल कॉलेज से आज यहाँ ज्वाइन किए। सो एक दिन के अंदर एक मेडिकल कॉलेज का फैकल्टी उठ के दूसरे मेडिकल कॉलेज में चला गया। वो आजकल वाइस चांसलर हो गया है, जो उसके हेड थे। तो उनसे जब पूछा गया कि सज्जन आप कौन सा विद्या पढ़ा रहे हैं लोगों को, व्हाट यू आर टीचिंग, प्रेशर है, एक बाबू का प्रेशर है। आजकल एक कुछ बाबू लोग हैं जो एडमिनिस्ट्रेशन में हैं, जिनको बस सब चीज़ आता है, उनको एक इम्तहान पास कर गए, सब चीज़ जानते हैं। तो ये स्थिति है। अब इस स्थिति में गवर्नमेंट का डिसीजन ये लेना कि इतना डॉक्टर्स होना चाहिए, हमारे ख्याल से कहीं ना कहीं ये हम लोगों के ऊपर अन्याय है। सो 2024 में क्या होगा? यू आर फोर्स्ड टू गो that India forgot the most rural crevices and cul-de-sacs. आपको उस एरिया में पोस्टिंग की जाती है जहां आपका कोई इंफ्रास्ट्रक्चर नहीं है, जहां आपने एमडी तक तैयारी की, बाहर ट्रेनिंग लिया, लेके आए, आने के बाद आपको वहां भेज दिया गया जहां एक कप चाय पीने के लिए आपको 2 किलोमीटर दूर जाना पड़ेगा। वहां आपसे एक्सपेक्ट किया जाता है कि हर दरवाजा खटखटाइए। हम लोग पहले मजाक में कहते थे कि डॉक्टर से इतना हो जाएगा कि हम लोग साइकिल पर चलेंगे, चिल्ला दे, किसी को दिखाना है दिखा लो, अरे आ जाओ भाई आ जाओ दिखा लो। वही हालत है। दरवाजा खटखटाए, कोई प्रेग्नेंट वुमेन है आपके यहाँ, वो जूता लेकर के दौड़ेगा आपके यहाँ कि और क्या तरीका है। सो ये किसने बनाया ये? लेकिन उन लोगों के बनाने वाले से ज्यादा दोषी हम लोग हैं। किस डॉक्टर ने इसका विरोध किया? कौन बैठा हुआ एडमिनिस्ट्रेशन में क्यों नहीं बोलता है? मरीज को आना है तो मरीज के पास, इंफ्रास्ट्रक्चर के पास मरीज को आना है, वहां पहुंचाने का इंतजाम कीजिए। आप गाड़ी क्यों नहीं देते हैं कि उसको उठा करके ले आए? आप क्यों नहीं फैसिलिटीज उसको देते हैं कि वो आने में संकोच नहीं करे, डॉक्टर चले जाए? क्या मजेदार बात है। और उससे मजेदार बात यह है कि हमारा समाज, जो डॉक्टर्स हम लोग हैं, आराम से हाँ हाँ जो हो रहा है सही हो रहा है। दिस इज द वे जो आपको 24 में फेस करना है। हम लोगों ने जब नौकरी शुरू की थी, वी हैव गॉट ए रॉयल सैलरी ऑफ 615 रुपीज। But believe me, I was very happy at that time because we had got respect for our profession. हमारे प्रोफेशन को रेस्पेक्ट था। लेकिन आज क्या है? आज डॉक्टर्स के प्रोफेशन को रेस्पेक्ट हमारे ख्याल से बोलना नहीं चाहिए हम लोग को, लेकिन देख लीजिए क्या है। तो इस स्थिति को लाने के जिम्मेवार हम लोग हैं, कोई और नहीं जिम्मेवार है। To call medical career a right was barely enslaving the doctors. हम लोगों को बंधुआ मजदूर की तरह ट्रीट किया जा रहा है। It delivers and bounds hands and feet to the mercies of the bureaucracy. Please think about this. हम लोग तो अब करियर खत्म कर रहे हैं, लेकिन अच्छा है जब तक जिंदा रहेंगे। हम लोगों के जिंदगी में अगर कुछ चेंजेज आता है तो आई विल बी द मोस्ट हैप्पी पर्सन। हिपोक्रेटिक ओथ को फिर से रिवाइज करना होगा। हम लोगों ने एक रॉन्ग कल्चर डेवलप किया है, लो फीस कंपटीशन, पेशेंट प्लीजिंग एट ऑल कॉस्ट, 24/7 अवेलेबिलिटी। हमने अभी भी कुछ बोर्ड देखा है, 24 घंटे सेवा उपलब्ध है। अरे भाई आप आदमी हैं, सुपरमैन तो नहीं है। नहीं हैं, कुछ लोग सोचते हैं तो हैं, तो भाई उन्हीं को मुबारक है। लेकिन ये मेडिकल में डॉक्टर समाज कुछ नहीं बोलता है। प्राउड स्टोरीज ऑफ इनह्यूमन वर्क। साहब हम तो 3 दिन नहीं सोते थे, 72 घंटा लगातार पेशेंट देखे हैं। क्या भाई तमाशा है? क्यों बोलते हो ऐसा? आप भी इंसान हैं, आपको भी आराम चाहिए। अगर दिमाग आपका सही नहीं रहेगा तो इलाज क्या कीजिएगा? So we are setting the wrong culture and self-exploitation and torture for the patients and for ourselves as well. Working pattern पर हम जितना कम बोलें उतना ही अच्छा है। Working pattern हम लोगों को सुधारने की जरूरत है। हम लोगों को खुद को सुधारने की जरूरत है, अपना हॉस्पिटल को सुधारने की जरूरत है। लेकिन इस जरूरत के साथ साथ सबसे पहले ये जरूरत है कि यू हैव टू अंडरस्टैंड योरसेल्फ। आप खुद को समझिए। हेल्थ एंटरप्रेन्योर होना आजकल कितना मुश्किल है। जो भी अस्पताल खोल रहा है लड़का, कितना मेहनत से, कितना कर्ज लेके, कितना क्या करके खोलता है। और आज उसके साथ सारे के सारे जो एक सिस्टम बना हुआ है, वो सिस्टम आपको टॉर्चर करने के लिए तैयार बैठा हुआ है। सो कृपया अपने आप को टॉर्चर से बचाइए। 24 के बाद यही होने वाला है, ज़्यादा जोर से if you will not prepare yourself. गवर्नमेंट ने आज तक या किसी कंट्री ने आज तक आपके मेडिकल इंस्ट्रूमेंट्स को सब्सिडाइज किया है? अभी हो रहा है कि अब जो आएगा बाहर का वो इंस्ट्रूमेंट यहाँ बना जाए, उसका कॉस्ट कम किया जाए, लेकिन कभी किसी ने नहीं सोचा। लेकिन उससे भी मज़ेदार बात है कि आपने कभी सोचा, कभी मांगा कि हम इंस्ट्रूमेंट अपने लिए खरीद रहे हैं? कौन डॉक्टर इंडोस्कोपी खुद करता रहा है अपने से लेकर के? किसी पेशेंट पर यूज़ करता है? कभी मांगा? क्यों नहीं मांगा? एक छोटा सा रिक्शा चलाने वाला वो 4 बार कहता है कि हमको तो यहाँ पर लाइन में हम लगाएंगे, चाहे कुछ करना है करो, मेरी जगह है। सब्जी लगाने वाला ठेला हम नहीं उठाएंगे। लेकिन डॉक्टर्स, हमारे यहाँ कल्चर में जो लाल हरा कल्चर आ गया है आजकल, उसका कुछ काम नहीं, वो नोचना है आपका। और आप सबसे अच्छे, आप जो हम लोग डॉक्टर सोचते हैं कि हम 30 मार खाएं, नहीं हैं। यू आर द बेस्ट यू आर द बेस्ट सब्जेक्ट फॉर टॉर्चर। आपको टॉर्चर करने में लोगों को बहुत मजा आता है। करप्शन हैज परकोलेटेड द होल हेल्थ इंडस्ट्रीज। द कॉन्फिडेंस ऑफ चार्जिंग फॉर द सर्विसेज आर नॉट देयर। आप अपने सर्विस को चार्ज कीजिए, कम क्यों लेते हैं? आप चार्ज कीजिए प्रॉपर, आप गलत भी मत बोलिए, बस सही चीज चार्ज कीजिए। जब बिगर हॉस्पिटल्स भी ये कर रहे हैं तो आप उनको मजाक मत उड़ाइए, देखिए क्यों, उनका भी कुछ कारण है, को समझिए। देन हैपेंड द एजेंडा मीडिया। एक एजेंडा मीडिया एक ऐसी चीज है जो आजकल जिस किसी भी नर्सिंग होम, अस्पताल या डॉक्टर्स, इवन गवर्नमेंट सर्विस में कोई अच्छा काम कर रहा है, उसके पीछे मीडिया पड़ जाए। सो यू हैव टू थिंक अबाउट दिस। सो देन व्हाट हैपेंड? This impossible to subsidize the OPD and diagnostic services, difficult to recover the cost of investment in current scenario, and medical tourism is extra hyped. इतना हाइप है इसका मेडिकल टूरिज्म का कि आप अखबार में खबर पढ़ के आप जाइए और दिखाइए। सो व्हाट इज हैपनिंग नाउ? गुड ब्रेन्स आर लिविंग मेडिसिन। अच्छा लड़का मेडिसिन में नहीं आ रहा है। पिछले 20 बरस का मेरे पास रिकॉर्ड है, एकदम ग्राफ नीचे आ रहा है। अच्छा लड़का जो भी है वो दूसरा प्रोफेशन ऑप्ट कर रहा है। कुछ और ग्राफ में है जो प्राइवेट मेडिकल कॉलेजेस का मैं देख रहा हूँ, जो पैसा लगा के जो जाते हैं, उसमें भी जो अच्छे लड़के हैं वो माँ बाप से लड़ जाते हैं, हम नहीं जाएंगे। सो प्लीज रीड दिस कोट, बड़ा अच्छा कोट है रॉबर्ट मुगाबे का। हाउ डू यू कन्विंस द अपकमिंग जनरेशन दैट एजुकेशन इज की टू सक्सेस व्हेन वी आर सराउंडेड बाय पुअर ग्रेजुएट्स एंड रिच क्रिमिनल्स? कैसे कन्विंस कीजिएगा? डॉक्टर्स में हम लोगों ने तो खत्म कर दिया। हम अपने यहाँ कभी किसी मिनिस्टर पॉलिटिशियंस को नहीं बुलाते हैं, किसी ऑफिशियल्स को नहीं बुलाते, कोई फंक्शन नहीं बुलाते हैं। डॉक्टर्स का फंक्शन होता है, डॉक्टर्स रहते हैं, हम लोग उन्हीं को चीफ गेस्ट अब बुलाते हैं। बट यहाँ जबरदस्ती हम लोग बना के रखते हैं। सॉरी अगर कोई बैठे हैं ऑडियंस में, भाई बुरा नहीं मानिएगा, दिस इज माई स्ट्रिक्टली पर्सनल व्यू, ये डॉक्टर्स का व्यू नहीं है। सो हम लोग का 2020 का ऑनवर्ड्स करिकुलम भी चेंज किया है। So we have to compete with them. So I think I will stop here. We have raised a certain very controversial point जो हो सकता है किसी को अच्छा नहीं लगा हो, लेकिन अगर नहीं अच्छा लगा हो तो प्लीज अकेले में बैठ के सोचिए। So thank you very much. Thank you audience and thank you chairpersons. Thank you. Well thought. अब हो गया?
Hello.
Thank you, Dr. Burma. It is the burning topic to our next generation, that how we will practice in 2024. One more question that I was in Bombay in 15 days ago. I have to consult a hematologist there, and in his chamber, it was written, and it was frame also, that written thing was frame also, that kindly do not discuss internet information to the doctor. Nowadays, this internet, however, they have facilitated some information, but as well as they have given us a much more burden. because the non-medical person discuss the things with the doctors, and sometimes it is very difficult to make him understand what the internet is saying. Moreover, in the Google and net, some wrong information also is there. So in next generation, the physician have to tackle this problem also.
Sir, please, sir.
Sir, your deliberation was very wonderful, sir, and it's really a time to think that whether the doctors are, this duty is right or responsibility of us, and it's really a eye-opening for us for the changing scenario we are going to face in 2024. Thank you very much, sir, for your kind deliberation.
Yeah, I can hear you, sir. Hear you.
So what is the proposed solution? How do you go about it?
Sir, you have yourself answered. No one talks about it. I
Yeah.
asked them to talk. Only thing
So
I
so you acknowledge the problem first,
Yes,
and then
acknowledge.
what are the next steps? So how do we go about it?
Sir, next step, if you acknowledge.
Maybe another lecture,
Not maybe, you will find a solution.
sir.
Definite, 101% sure. If it is a personal solution, you will find it. If it is a general solution, you can discuss in a group. Discuss in our societies. In our societies, I just tell you one anecdote, that in one meeting, say chief secretary, principal secretary, all, they were there. I was the only doctor who was member of that committee. So when it was discussed that we have to finalize certain things, which to my mind was absurd. I'm telling you just what they are finalizing. They were finalizing instruments for the PHCs. The total amount was approximately 480 crores. So I said, I cannot do anything. I am a doctor. I don't know anything about instrument. Nothing about a screw and pinch about that. I don't know anything. So when we have to finalize instrument, bring a biomedical engineer. He has to say that this is good, then only I will purchase. Otherwise, I'm not going to sign. That project was shelved. And I was blacklisted from the meeting next time.
Thank you very much, sir.
Okay, sir. Thank you, sir.
Sir, just want to lodge my protest against the statement that only 4% people are paying tax, are taxpayers. I think everybody who wears shoes, everybody who wears clothes, everybody who eats rice is paying taxes. But a few intellectuals has prevailed upon the mind of the people that we only are the taxpayer or you are the consumers of the nation. It should not be the way we think.
Sir, please.
We all are paying. Everybody, a rickshaw chalak is also paying.
I was talking about direct income taxes.
No,
I was not talking about
he
taxes.
also taxpayer.
Direct taxpayer. I was talking about direct income taxes. Only I was talking about direct income taxes. Everybody is paying what you are paying, but direct income taxes, please don't take it otherwise. These are the propagandas which are being given by many people.
Thank you, sir. Sir, for your excellent oration. Let's go to the rear side for collection of the mementos. Okay, thank you, sir.
Thank you so much. Thank you so much, everyone, for your kind and patient listening. And now our next topic that we are going to cover here is movement disorders in children. So this is going to be our next topic. And to chair the respective session, I'd like to invite Dr. J.B. Mandal, who is a professor in SKMCH, and then Dr. Amit Kumar, who is assistant professor at IGIMS, and also Dr. Ashutosh Sinha, who is the director and HOD of Pediatrics Department at Fortis Hospital. So I'd like to be requesting all of the three chairpersons to kindly be seated. And then I'd like to invite our keynote speaker, our next speaker, Dr. Anup Verma. So thank you so much. The next topic is going to be the movement disorders in children. And I'd like to request the chairpersons to please give the audience a briefing about Dr. Anup Verma. Thank you so much.
He is from Raipur, Chhattisgarh, a legend interested in pediatrics, neurology, and clinical genetics. He has many publications in the textbook, PI textbook of IEP textbook, and the various awards. He was given Doctor of the Year Award by the IMA, National IMA, FIAP member, FIMS, FCGP, and he is honorary fellow of the Academy of Pediatrics Neurology. He has various audition and the affiliation to the National EBM, National Vice President. He was the National Vice President IAP 2005, National Chairperson Academy of Pediatrics Neurology 2008, CWC member of Central IMA, CGA State President of IAP 2006, CGA State President of Chhattisgarh IMA, IAP Constitutional Committee member, and now he is the Central Zone Coordinator of ECD in 2022-23. So I have the legend, Dr. Anup Verma. He will talk about the movement disorders of the children.
Thank you, Mr. Chairman, sir. With due regards and respect to our chief guest, our senior members, our thanks to the organizing committee for giving this prestigious platform and flair of Mithila culture, which this is the first time I am witnessing this area. Heads off to organizing chairman, Dr. Ashok Kumar, sir, Secretary Dr. Islam, and every member of organizing committee, and due respect in regards to President of Bihar, Dr. Shivbachan Singh, sir, Dr. Mishra, sir, and Dr. Gupta, and ladies and gentlemen. My topic has been a very interesting one, and it is out of the outpatient department, how we are focused to pick up the abnormal movements. So here we go. Friends, to acquire knowledge, one must study, but to acquire wisdom, we must observe. My whole of the talk is based on how we observe. We all see patient day in and out, and most of the time it is at the level of spinal. We are seeing 50 patients in an OPD, 100 patients in an OPD. Is it justified? How much time you are giving to a single patient? 3 minutes, 4 minutes, 5 minutes, and you are also managing the OPD, your own hospital or your staff and everything. So this is very important that I remember the Sir William Osler, what he has said, to study the phenomena of disease without books is to sail an uncharted sea. But to study the disease without patient is not to go to sea at all. What our brain knows, we try to explore in our patient. And that is, whole of the lecture is totally based on the way of observing the patient. Now, a picture is worth 1,000, but it is a known fact. And it is also a known fact that movement disorders are better observed than described. If you read the text, what is chorea is defined, what is dystonia is defined, what is stereotypy, what is tics. So it cannot be a very easily graspable the topic. But when you see a video and then correlate, it will be very, very helpful for that. So whole of my talk is based on improving the power of observation, bridging the basics. It is all about the pattern recognition and various case scenarios we will see. We divide the movement disorders into two types. Most of the time, we are, as a pediatrician, we are focused on the hyperkinetic disorders like fast movement disorder like choreoathetosis, dystonia, like that. But we do have a slowness of movement that is known as the hypokinetic movement disorder. So friends, photography and videography is the power of observation, not the application of the technology, that we have to remember. This is the spectrum of movement disorder. You name a movement disorder, it is here. So you are seeing that the fastest movement disorder is the myoclonus and the slowest one is the dystonia. Now this is the anatomical substrate. If you are talking about the chorea, you are seeing that it is related to caudate nucleus disturbance, dystonia to the globus pallidus and putamen, and subthalamic nucleus related to the involvement, the precipitation of the balismus as well. Can you see this video? So what are you seeing? This is a seizure disorder, or you are thinking that this is a movement disorder? Definitely, we will see that how we can basically differentiate whether this movement disorder is this abnormal movement is a movement disorder or a seizure disorder. So what the first thing is, the movement disorder disappears during sleep, whereas the seizure may persist or may worsen. Now you can see that in this video, movement disorder have a more stereotypic appearance and more persistent than seizure. Seizures are accompanied by loss of consciousness and awareness, but you will not see a patient of chorea becoming unconscious and other movement disorder as well. And you are also witnessing that any epileptic condition will have a classical EEG presentation, whereas movement disorder will not have a classical presentation of an EEG. That is again so we will go here for the pattern recognition, or the senseful observation is the pattern recognition. For any patient who is sitting in front of you and exhibiting abnormal movement, just focus on the head, then trunk, and then the upper extremity. So there is no more difficult art to acquire than the art of recognition. That is very, very important. You can see that this is the clinical pearl out of the pattern recognition. Just observe the video. Well done is half begun, what Aristotle has said. Focus on the face of the child exhibiting abnormal facial expressions. He is not stable. See the hands as well. So this is a classical presentation of chorea along with the athetosis. So how chorea is recognized? Just focus on the videos. You can see that this is a non-repetitive, brief, rapid, unsustained movements are there. They are more proximal. Just focus on the videos what I am showing to you. There's a random appearing sequences there, random in timings, and each movement has a distinct start point and the end point. Movements are more, just see the face. Movements are more marked on the face, the upper extremities are more involved, and then the constant motion or fidgety, you can see that they are not stable. Now, if you plot athetosis, chorea, and balismus, they are almost the same. Just difference in the range of amplitude movement. For example, athetosis is a very small writhing movement as it is depicted in this way. Chorea lies between the balismus and the athetosis. So overlap is the rule rather than exception in movement disorders. Now what is tics? You are seeing all these videos, they are examples of various sort of tics, and they are rapid, non-voluntary, repetitive. They are the segmental movements. If it is less than 6 months, they are said to be a simple tic, and if it is lasting for more than 6 months, they are said to be chronic tic. You can see that this single brief stereotic movement, for example, the eye blinking as the child is exhibiting. Complex motor tics means there are involvement of the two muscle group. It could be a phonic sort of thing, what is known as the phonic tics, phonic or vocalization. Then what is dystonia? Dystonia are the involuntary sustained. See the amount of tremendous pain the child is exhibiting. Torsional muscular movements are there. You can see they are really painful. Abnormal postures you are seeing here. Extreme, either in the extreme extension or extreme flexions are there. You can see the abnormal posture. They can be triggered by the voluntary movements. Foot inversions and lordotic postures are the examples of dystonias. There is definitely an overflow of these movements. We can see the spread of motor commands to the surrounding muscles as well. Here is the another phenotype of the phenomenology of the movement disorders, the myoclonus. So what is myoclonus? It is the sudden shock-like jerk is the myoclonus. And these are all children exhibiting the sudden shock-like jerk is the myoclonus. And they have a lack of identifiable postures for a contrast to dystonia. There is a sudden jerks, that is the contrast to athetosis as well. And it cannot be suppressed as the tics can be suppressed. Now here is the tremors. These abnormal movements are categorized under tremors. They are the rhythmic oscillations and rhythmic alternate contraction of agonist and the antagonist as well. There is a symmetric velocity in both the direction. There is a lack of jerk and release cycle as we see in the myoclonus, and can be associated with the dystonia. You can see here as the dystonic tremors as well. All these female patients, they are exhibiting the repetitive pattern movement, what is said to be in the stereotypy. They can be voluntary suppressed, simple back and forth movements are there. Lower limbs are typically not involved in stereotypies, as you are seeing in these videos. Mostly they are bilateral and there is no premonitory urges are there. Mostly they are seen in the developmental syndromes like autism. We have ADHD groups is there, can be seen in the healthy children in preschool age groups. Now let us see what are the causes of acute sort of chorea, and these are the list of acute chorea. It could be autoimmune, for example, Sydenham's is an autoimmune type, vascular, mitochondrial, toxins, and we have psychogenic presentation of chorea as well. How typically chorea presents? We know all that. It all begins in the infection of the throat, typically by the GA-BHS. 4 to 6 weeks after the episode, there is a presence of such type of abnormal movements can be there. On 20% of these patients can have hemichorea. You see the tongue of this patient. As if there is a bag of worms are there. Signs of this. You can see the typical tongue fasciculations you are seeing in a case of rheumatic chorea. They can occur spontaneously and intermittently. Muscular fibrillar contractions are there. These are varieties of classical signs of chorea. This is the spooning sign, the first video. Second is the pronator sign, then the darting tongue, then the milk-maid grip. That has to be remembered. This is the typical gait. You get the unstable. See the video? They the lurching quality. The dance-like, affecting the trajectory of the lower limb. See the video. And we should not afford to miss the lupus erythematosus and the facial rash in a patient. See the palatal rash in a case of lupus. And this lupus can have a presentation of chorea, what is called as a lupus chorea, and the onset of is this 7 years before and 3 years after the systemic manifestation of this. Now, this is a patient who I have just seen a week back presented with the abnormal titubation. You can see the head of this patient. There is a oculomotor apraxia. That means if you ask the patient to look laterally, instead of moving the eyeball laterally, whole of the head will moving toward the left and the right. This is what is the oculomotor apraxia. MRI was done. See, what is this? This is the molar tooth appearance in the MRI. This is the classical presentation of Joubert syndrome, that is the cerebellar hypoplasia or agenesis. And you can see the classical fundus picture. There is the deposition of the drusen over the optic disc and the partial optic atrophy as well. Now we can see the role of vitamins in the presentation with different types of tumors. Here, the abnormal body movement, there is a regression of the milestones, pallor, pigmented hairs are there, coarse tremors of the head. What is this? Classical presentation, you can see the head tremors is there. See, the hair will give you a appearance of the clue. This is the classical ITS, infantile tremor syndrome. You can see the thin pigmentary hairs, anemia, hypotonia, regression of the milestones and tremors. In spite of over more than 6 decades of the presence of this condition, we could not have an ideal etiology to conclude that this is a classical, but still we have now known that vitamin B12 is in picture to control ITS as well. This is the long-term cognitive follow-up. We have followed this patient for 5 to 6 years, and this is the serial video of this patient. The movements have decreased, but definitely the cognitive and neurodeficit can persist even at the later age groups. Another patient, just see depigmented hairs, eyebrows, you can see the tremors of the head. Another patient, now the condition is known as neurocutaneous infantile B12 deficiency syndrome, or NIB syndrome, and not the ITS. See the, just close the eyes and listen to it. So what was this? This is the bleating goat, bleating of a lamb cry. This is the classical. This is what is described in the book. This is, you can see the another patient of ITS, you had seen the bleating goat cry. And another patient with having the vacant stare, see the tremors, tongue tremors are there, Parkinsonian-like face, and tremors, expressionless face is there. So you have the new name is the NIB syndrome, and we know that B12 deficiency can account for the major neurological morbidity as well. This is the skin changes, spars, less than 3 years of age, head tremors, anemia, and typical cry. Another patient, see what he is doing, excessive cry, excessive irritability is there, not able to sit even. You can see the first video, he is sleeping and there is a mini myoclonus are there, jerks are there, and upon able to, he is not able to sit even, jerks are there. What is extremely irritable. This is what is the truncal ataxia. And see the eye movement of at the video number 4. This is the opsoclonus, is very important. It is the feature for general pediatrician. Nobody, no patient will go to neurologist. It will be by the pediatrician who pick up this abnormal and then adequately refer to the higher specialty as well. So this is a classical presentation of OMAS. OMAS is the opsoclonus myoclonus ataxia syndrome. So this is a classical example of OMAS, and we know that neuroblastoma is related to OMAS, ovarian teratoma, even the flu vaccine, and there are certain infections which can precipitate OMAS. This was the case. It was detected that the neuroblastoma was at the D2 level. It was operated upon, and this is the follow-up of this patient. Just by opsoclonus presence, it was investigated and upon treated as well. Another patient, just see the video number 1. See the chaotic eyeball movement, irritability, ataxia, again a non-tumor type of OMAS. You can see this. Did you see the, this is the third patient. See the number 1 video, see the focus on the eyes, and this is the another patient of OMAS. CT chest, abdomen was normal, VMA was absent, so this is non-tumor group. So my presence of myoclonus, opsoclonus, ataxia give rise to, they give you a clinical clue for the presence of OMAS. Another patient, female child, the diagnosis is then and there, just see and diagnose. Female patient doing hand-wringing, hand-washing movement, diagnosis. This is a classical Rett syndrome. Even in your camera, depicting the patient sitting in the OPD, you can, from the camera, you can pick up that she is doing an abnormal stereotypic movement, autistic behavior. This is the gait abnormality, stereotypic hand movement, typical Rett syndrome is there. Another patient, autistic behavior, bruxism, wriggling, you can see. Another patient, see the stereotypic hand movements. Another patient, we all know that it is all due to the mutation in the MECP2 enzyme. 90% of these patients, they have a MECP2 mutation and less than 5% CDLK5 mutations. And this is a very classical, I don't have a, are you hearing? This is a breathing, a daytime breathing abnormality, a dysautonomic feature is there in this patient. So MECP2, you can see that mutation is there, and this is regression, female patient, MECP2 mutation, hand washing movement. This is a pearls to practice for the another patient. See the what type of abnormal movement child are exhibiting. The number one is the patient is exhibiting coriform movement. They see the vacuous smile, the dystonia, the hemidystonia. So any clue? Eyes will give you a classical clue. Here is the eye. What is this? This is classical KOF ring, and the diagnosis is the Wilson's disease. And you can see whole of the family. I have captured the photograph, and you can see classically in the patient you have a brownish, yellowish pigmentation all around the decimate membrane, and this is the. And we know that face of giant panda is seen. Another patient of the Wilson's disease, see the cerebellar sort of presentation, and you can see the coriform, the tongue movements are there, and see the photograph number 3rd, KF ring is there, and you see the amount of type of wing beating tremor the child is exhibiting. If you ask the patient to abduct the shoulder like this, and there is a classical exhibition of the tremors, what is known as the wing beating tremors. Another case, the video number 1 you are seeing is the there is a coriform movement, and ataxia is also there. And upon examination of the eye, he is having an oculomotor apraxia. As I have already told you that oculomotor apraxia means if you ask the patient to look laterally, instead of moving the eyeball laterally, whole of the head will move here. Similarly, so this is a oculomotor apraxia. Now see the closeness of the sclera. What is this? These are all the leash of conjunctival vessels are there. So this is another patient with ataxia, and the conjunctival the telangiectasias are there. So this is classical tortuous conjunctival vessel, acanthocytes are seen, and IgA reduced, and this is classical presentation of ataxia, telangiectasia. This is some movement disorder can be precipitated by allowing the excess of movement. This is what is known as the paroxysmal kinesogenic dyskinesia, as the child having a dystonic adoption of the dystonic posture of the right upper limb. Another. You can see the child is asked to stand from sitting position. Now see the dystonic position is adopted by this. This is again PKD. These are the videos which are very, very important. These are sent by the parents. All patients are in infant doing tonic posturing, adduction of thighs. You can see this is a gratification phenomena, and we all know that this may be very disturbing to the family, and it is seen between 3 to 3 months of age. All these are the patients who are doing gratification phenomena. Pelvic thirsting is there, and imitates any sort of semiology. That is again a very important. See, all these patients are exhibiting. These are all videos sent by the parents. So videotape is invaluable in the diagnosis. That is very important. Another patient, these are the group of patients, they are exhibiting shivering attacks. What is this? These are shuddering attacks. These are all benign condition which is known as the shuddering attacks. No treatment is required, just counseling. Just focus on the chin of this child. Tremors. And the father is saying that he also had a similar sort of chin vibration, and this is what is known as the hereditary chin trembling. And this is the second patient, and just 2 slides more. This is the home recording of event. That is very, very important, and it is said that it is almost superior, or if not superior, it is almost in the similar level for the MRI and other diagnostic modalities. So home video recording is non-inferior to video EEG in the diagnosis of epilepsy or movement disorder. So these are the recommendation for a good qualities of video. You can see face record, whole body record, lights on, simple episode recorded, 2 or more episode recorded, and it has to be, your lights should be on, steady position, interact. So this is very important. So friends, lastly, history is not his history, but much more, as Dr. Amdekar has said. Always try to explore the history so that it can be senseful seeing is the observation. The whole of the talk was based on the observation. To acquire knowledge, one must study, but to acquire wisdom, one must observe. And you can see the classroom, a video is worth 1,000 pictures. I cannot define an elephant unless I have seen one. You can see that the teacher is also explaining that a lot of videos is incorporated in the presentation for better learning. Learning disease is never complete. Learning disease is never complete. That it is very, very important message that you have to churn your experience with the available science. So it is not only the books, but the presence of videos, or you see the patient in person. Thank you so much.
Thank you, Dr. Verma. I would like to actually congratulate you and thank you for giving such a beautiful display of various movement disorders, and particularly of help would be those which are actually normal variant and which are benign for the general pediatricians. And I always believe, in fact, pediatrics is an art of observation, and this movement disorders is more so. And this comes with a lot of experience and coaching as well. I mean, if you are under someone who's coached you about these disorders, it helps a lot. And the one take-home message which I would take from you, your slides, is how to make use of the video recordings. I mean, that's the most important part that we should ask from the patients, and observe it again and again. And if you find it any problems, then refer to a particular place.
Sir.
Yeah.
Points well taken, sir.
Thank you, sir, for such a wonderful lecture. No matter how we are going to read, this one lecture is going to clear all our doubts. And I am sure everyone of us is thinking, have we misdiagnosed that case which we saw 10 days back, something like that. So this video is something which is a real eye-opener. Thank you, sir. Any questions from audience?
Of course, a wonderful presentation by Dr. Anup Verma with clear-cut presentation, video presentation, that from hyperkinetic to hypokinetic, the whole abnormal movement lies between this. And of course, the video was very much informative, and it was simplified. And in my opinion, you need much more time than this your allotted time. So now the question is open to the general.
Sir, please. Hello.
Sir, your question.
Sir, infantile tremor syndrome, how long we have to treat with vitamin B12, sir?
Not more than 3 months.
Thank you, sir.
Many thanks to Dr. Anup for his excellent presentation. And the video, every PG should watch this video in their leisure moment and just to enjoy it. Thank you very much. Let us go to the real stage for collection of mementos. Thank you.
Thank you so much, Dr. Anup Verma, for your wonderful presentation. And now I would like to take the segment forward. And the next lecture is going to be the guest lecture, and it is going to be on salt or no salt to the baby. And to chair this session, I would like to invite Dr. V.K. Singh, the legendary Dr. V.K. Singh, sir, needs no introduction. He is our finest pediatrician of Darbhanga. And then I'd like to invite Dr. Ravi Prakash, the Director and Chief Consultant of Shishu Seva Sadan. And then Dr. Arvind Ojha, who is the HOD of Pediatrics cum ACHD admin of CSSH ECR at Patna. And our next keynote speaker is going to be Dr. Maya Shankar Prasad. And I'd like to request the chairpersons to please take your respected seats. And after this, I'd like to be requesting the chairpersons to please give us a briefing about Dr. Maya Shankar Prasad and his achievements. Thank you so much.
It's been a great pleasure in introducing Dr. Maya Shankar Prasad, and I have had the privilege of working under him during my stint in Darbhanga Medical College. Though it's a whole big list which I have to tell you. It may require a whole book to describe his 75 years of life. He's a native of this town, Rai, and he passed his MBBS from Darbhanga Medical College in 1970. These days, there was no post like junior or senior resident, and the internship was for 6 months only. He joined as a junior house physician and then as a senior house physician in the Department of Pediatrics, and he completed 1 year of house job, which was essential in those days for admission in PG course. Then he took up an offer of a job in Institute of Medical Sciences, Varanasi, under BHU. He worked there as a demonstrator in the Department of Anatomy, and since he had a clinical background, he could not stay long in the Department of Anatomy and decided to say goodbye. Then he joined as a medical officer in a rural setup in present Jharkhand. Then he worked his way up with extensive tours in the forests and hills of Jharkhand, and then had come an opportunity for admission in PG degree course. I'll cut short his resume because it's going to take a whole lot of time. But he has been retired as professor of pediatrics in Safdarjung Medical College, and presently after retirement, he's working in a teaching institute such as BP Koirala Institute of Health Sciences, Dharan, and SGT Medical College, Gurugram. He's multilingual, and he's presently leading a complete retired life at Dwarka, New Delhi. Please go ahead with your presentation.
Thank you, chairpersons. My dear fellow pediatricians, ladies and gentlemen, friends. Well, my presentation is a little bit different presentation. All the speakers, they are speaking on academics. I too have academics, but very little. I shall be talking to you, telling you stories, and I shall tell you my experience. The topic is definitely this: should we give salt or we should not give salt to the baby? But before coming to the topic, I have to dedicate my presentation to my professor, my teacher, and my mentor, Professor B.N. Dasgupta. He was professor and HOD pediatrics at this institution, Darbhanga Medical College Hospital at Lehariya. Professor B.N. Dasgupta was a teacher of teachers, and that is true, because there was a time when you go to any medical college in Bihar, and when I say Bihar, it means it including Jharkhand too. You go to any medical college, and you would find his ex-student as among the faculty members. That's why he was known as teacher of teachers. And as I told you, he was my mentor too. He was born on 9th December 1919. Well, I don't know where was his birthplace. But one thing I definitely remember, once he told me that his father was posted as senior deputy collector or STO at Lahariya, and he had his official residence at Pandasarai Road in Lahariya. That much I know, but I can't say where was he born. Unfortunately, we lost him on 4th February 1992. So, inna lillah wa inna ilayhi raji'un. Well, this is an Arabic expression. Word by word meaning I cannot say, लेकिन इसका भावार्थ यह है कि हमारा शरीर 5 तत्वों से बना है और उसी 5 तत्व में विलीन हो जाना है. Well, Professor V.N. Das Gupta was British trained, and those who know Britain, they can understand what do I mean, and then I will explain it more. The British people, they speak very softly and in a very low volume of voice. I still remember when I visited London, the immigration officer at Heathrow Airport asked me something. He was speaking very softly, and the volume of his voice was very low. I think hardly 10 or 20 decibel रहा होगा, उससे ज़्यादा नहीं. So, as per habit, I said, "I kathi." So this is Bihari expression. So he repeated his question, and I answered appropriately. He was just asking that, what is the purpose of your visit and how many days you will stay here? Well, my purpose of saying so is that Professor B.N. Das Gupta was also very soft spoken, and he spoke always in low volume of voice. At least during the whole period of my contact, I never heard him speaking loudly. But he has his own style of rebuking you. Well, in the year 1974, I was first year PG student, and you know how careless I was. Previous day he said something I did not hear because he was very soft spoken and his voice was very low volume. Next day morning he asked me, "Hey, ईठो जो बोला था किया कि नहीं?" Now ईठो जो बोला था, believe me friends, my heart stopped beating. I was standing with cardiac asystole. Both ventricles were standing still. Nothing. But second atomic bomb came. He said, "You have developed interauricular fistula." I was just trying to comprehend and understand what is interauricular fistula. Then he himself said, "इस कान से सुनता है और उस कान से निकाल देता है, पता नहीं MD कैसे कंप्लीट करेगा." So those were his words. उस समय चाहे जैसा लगा, लेकिन आज लगता है कि those were blessings for me, which made me man. बांग्ला में बोलूं तो সেই বকনি খেলে সেই গালটা শুনলে আমি মানুষ হলাম. That is in Bengali. So, for such a great personality, मेरा कोटि कोटि नमन उन्हें, great salute to him. Now coming to this topic, whether we should give salt or we should not give salt to babies. And frankly speaking, my dear friends, gentlemen, I was not knowing about this topic. I had no idea about this topic until 2013 when I visited my relatives in Pennsylvania state of USA. They had a baby girl, 2.5 or hardly 3 years old. The mother of baby asked me, "Mama ji, isko namak kab se khilayenge?" I was surprised. नमक खिलाते हुए तो किसी को मैंने देखा ही नहीं था कि चम्मच से या चुटकी से नमक खिलाते रहे हो बच्चे को या बूढ़ों को भी। क्या पूछ रही है? तो मैंने कहा कि भाई दाल सब्जी में तो नमक होता ही है, फिर ऊपर से नमक देने की क्या जरूरत है? दोनों हस्बैंड का वाइफ का मुंह खुला रह गया इससे। फिर हस्बैंड ने कहा कि जब ये 6 मंथ की थी तो पीडियाट्रिशियन ने कहा था कि नमक मत दो, लेकिन उसने ये नहीं बताया कि कब तक मत दो। तो हम लोग अभी तक इसको नमक नहीं देते हैं। इसके लिए खाना अलग से बनता है, इसकी दाल अलग बनती है, सब्जी अलग बनती है, हम लोग उसमें नमक नहीं डालते हैं। सो दैट वाज माय फर्स्ट एक्सपीरियंस। सेकेंड एक्सपीरियंस, it was not my experience, it was experience of Dr. Vishnu Priya Sahu. She was my colleague in the Department of Pediatrics at SGT Medical College in the district Gurgaon, Haryana. One day she came and she was very sad. I asked her, "What happened? Why are you so sad?" She said, "Sir, I feel insulted." What happened? She said, "Morning I went to drop my son to the school bus and other mothers were standing. So one of them asked me कि बच्चे को कब तक नमक नहीं खिलाएंगे? I said, क्यों? नमक तो खिलाते हैं। तो वो माँ गुस्सा गई, बोलती है, "What type of pediatrician you are? You don't know कि 5 साल तक नमक नहीं देते हैं?" So the sentence that what type of pediatrician you are, that made me sad. I feel insulted. So that was our initial experience to this topic, whether we should give salt or not. Common salt, coming to common salt. All of us, we take salt every day. शायद ही कोई होगा बाबा रामदेव का चेला जो नमक नहीं खाता होगा। वैसे I remember कि मेरी माँ एक व्रत रखती थी, उसको अनोना व्रत कहते थे। तो वो अलग चीज है, बस रामदेव के चेला को छोड़कर और मेरी माँ को छोड़कर और कोई नमक छोड़ता नहीं था। And you know, salt is the main source of sodium to our body. And I need not tell you, you are all learned fellow, you have read the physiology, anatomy and everything in pediatrics. You know what is the role of sodium in our body. I am not going to tell you. But one question comes to my mind, why only humans take salt? There was an answer in a WHO book I have found, and it went like that life evolved in sea. Life evolved in sea water, which is salted. Later on, life came out of the sea on the land, and then differentiated in many forms: chordate, non-chordate, vertebrate, invertebrate, mammal, non-mammal. So, talking about other animals, I watch National Geographic, I watch Animal Planet, I watch BBC Earth. There they show that lion, cheetah or tiger, they are killing the prey and eating. आज तक किसी भी शेर को नमक छिड़क के खाते हुए नहीं देखा है। वेजिटेरियन की बात करें तो ब्यूटीफुल पैंडा को दिखाते हैं जो बड़े चाव के साथ चटकारे लेकर के बांस बैम्बू खाता रहता है, उसको भी नहीं देखा कि नमक छिड़क के खा रहा है। अपने रियल लाइफ में गाय बकरी को देखा है घास चरते हुए, किसी को नहीं देखा है कि नमक छिड़क के खा रही हो। तो why only mankind? Why only we take salt? एक इमेजिनरी एक्सप्लेनेशन है मेरे पास कि on the 7th day of Genesis, when God created Adam, he forgot or he missed to install the mechanism or machine which could preclude the need of salt. So that's why we are taking salt. That is my just imagination. नमक हमें बहुत प्यारा है. काफी सारी, there are so many stories. You must have heard that story कि एक राजा की कई लड़कियां थी. He asked his daughters, how much do you love me? तो they replied differently. किसी ने भी कहा उफक से भी ज्यादा, आसमां से ऊपर, सितारों से भी ज्यादा, वगैरह वगैरह. एक ने कहा कि मैं आपको नमक से भी ज्यादा प्यार करती हूं. राजा गुस्से में आ गया कि एग्जाम्पल के लिए और कुछ नहीं मिला, ओनली नमक. सॉरी. एक दिन that princess arranged that no salt was added to the food items. राजा ने जैसे ही मुंह में डाला, बड़े गुस्से में आ गया. उसने कहा बावर्ची को पकड़ के लाओ, खानसामा को पकड़ के लाओ, इसका सर गर्दन से अलग कर दो. तो वो लड़की प्रिंसेस बड़े बाअदब और नम्रता के साथ, आदर के साथ अपने फादर को बोली कि देखिए, एक दिन नमक नहीं मिला तो आप कितने गुस्से में आ गए, इसलिए मैंने कहा कि मैं आपको नमक से भी ज़्यादा प्यार करती हूँ. That was the story. My own experience, यहीं लहरिया सराय में there used to be a open field, उसका नाम था पोलो फील्ड. अभी भी है क्या पता नहीं. तो हम लोग उसमें फुटबॉल का मैच देखा करते थे जमीन पर बैठकर, और चिनिया बादाम फोड़ते थे. चिनिया बादाम यानी मूंगफली, मराठी में बोले तो सींग दाना. वो फोड़ करके हम लोग खाते थे. और वो चिनिया बादाम वाला जो नमक देता था, गजब का टेस्ट होता था उसका. घर पे कितना भी कोशिश किया वैसा नमक नहीं बन सका. तो नमक के तारीफ में हम काफी देर तक बोलते रह जा सकते हैं, इसलिए इसको यहीं बंद करता हूं. लेकिन इतना प्यारा होने पर भी हमारे यहाँ लोगों का नमक का बैड इफेक्ट्स टू द न्यूबॉर्न मालूम था. वो कैसे, वो बताता हूँ. बिहार में, पर्टिकुलरली नॉर्थ बिहार में, जब कोई बेटा नालायक निकल जाता था तो माँ बोलती थी कि अगर पता होता कि तू ऐसा कुपुत्र निकलेगा तो जन्मते ही नमक चटा देती. इसका मतलब उसको मालूम था कि नमक देने से न्यूबॉर्न शायद ऊपर चला जाता है. और अंग्रेजन सबको तो आज पता चला है. WHO recommends that up to 12 months of age, don't give any salt. Our main reason of not giving salt is fear of development of the hypertension. Not now, but in future too. पानी है. माइनर रीजन्स बहुत सारा है. कहता है कि नमक दोगे तो जो नेचुरल टेस्ट है वेजिटेबल का वो बच्चे को पता नहीं चलेगा. ये सब माइनर रीजन है. और एक बार नमक की आदत लग गई तो बच्चा शायद ब्रेस्ट मिल्क नहीं पिएगा. किडनी पर ओवरलोड की भी बात होती है, किडनी स्टोन की भी बात होती है. कहते हैं नमक दोगे तो कैल्शियम एक्सक्रीशन बढ़ेगा और स्टोन फॉर्मेशन हो सकता है. So these are minor reasons. Let us see it age-wise. First 6 months में we advocate exclusive breastfeeding and nothing else. Breast milk contains enough sodium to meet the baby's requirement. So it is out of question to add any salt. 7 to 12 months of age, we add contributing feed. complementary feeds. These complementary feeds, they all contain sodium. So the sodium present in complementary feed plus breast milk, they meet all the sodium required by the baby. So there is no need of adding any salt. After 1 year of age, up to 3 years, both American authority and European authority recommend giving half teaspoonful of salt per day to the baby. Now, उस झगड़े में मत पड़िए कि अमेरिका का हाफ टी स्पूनफुल कितना होता है और यूरोप का हाफ टी स्पून कितना होता है. After 3 years of age, baby can eat from the family pot. लेकिन added salt मत दीजिए. And I will personally say that not only the baby, the whole family should not take added salt. कम से कम salt खाइए. और हमारे खाने के टेबल पर एक बड़ी खतरनाक चीज होती है, उसको हम नमकदानी कहते हैं. तो नमकदानी से छिड़क छिड़क करके खाने पर नमक मत डालिए. That will protect the family also as well as the baby. And main concern, as I told earlier, it is high blood pressure, hypertension. कहते हैं कि वृद्धावस्था में उच्च रक्तचाप का बीजारोपण शैशव काल में ही होता है. पता नहीं ये बात कहाँ तक सही है, विद्वान लोग बता सकेंगे. So, to summarize, salt is not given to the baby under 12 months of age. From 12 months to 3 years, give half teaspoonful. And from 3 years, baby can take the food from the family pot. This boy, I think he is taking appropriate diet. क्या ले रहा है? शायद मिल्क एंड बनाना या मिल्क या कॉर्नफ्लेक्स. और सबसे बड़ी बात है, अप्रिशिएट करने की बात है कि खुद खा रहा है, अपने से खा रहा है, मदर को खिलाने की जरूरत नहीं है. एंड रिक्वेस्ट है, प्लीज डोंट माइंड द बॉडी पार्ट हैंगिंग इन द कटोरा. जो बाउल में बॉडी पार्ट है उसको मत देखो. हाँ, उसमें सॉल्ट होगा, हो सकता है जो डाल दे उसमें. So, away from the topic again, this is the Golden Bridge in Vietnam, and we are standing in front of that Golden Bridge. We means myself and my Sharike Hayat. Sharike Hayat बोले तो धर्मपत्नी. So, my presentation was very short. मैंने 10 मिनट पहले ही खत्म कर दिया. इसके लिए हमें कुछ इनाम मिलना चाहिए.